Remember what I put on WhatsApp? No drugs. Okay, that's what marijuana did to my brain cells when I was a young person. It killed a bunch of them. There you go. Record to
Recording
cloud.
in progress.
Okay, good evening, everyone. Frank Nuki here, one of the senior instructors, CICs for LaGuardia Community College. We are going to be reviewing chapter 13, chapter 30, and 31. To my knowledge, if I remember correctly, is shock, abdominal, and chest. Okay, it's very important that we go to each one. Now, you all already did these lectures. I'm not going to spend too much time on this, but I'm going to say, okay, remember this, because this is how they love to give you test questions on. This is how the state does this. Make sure you know that. And remember, I will send this recording to you all once we're done on your WhatsApp. Okay, you know it says shock and resuscitation. You know it always begins with National EMS Educational Standards competencies. You know, it talks about respiratory failure, respiratory arrest, cardiac failure, or cardiac arrest, and then that post-resuscitation management. We're going to talk a little bit about that. This is always test question right here. In your book, you better know the word shock, hypoperfusion. They give it you either or in class or on the state. You'll see it. So if they ask you hypoperfusion, make sure you know what it says there, that definition, exactly what is there. Okay, defined as inadequate cellular perfusion. And we're talking the exchange of oxygen, water, glucose, and so forth. Okay, it always does that. But just need to know that word right there, hypoperfusion, or the word shock. It's interchangeable. You need to know the word homeostasis, this word. You need to know that because your body always tries to keep that internal environment constant. So when something's wrong with you, your body lets you know through signs and symptoms. When you're not feeling well, whatever it may be, your body tells you something. So it's up to you to recognize this as a person who's normally healthy. Okay, what's going on? Maybe coming down with a cold. I'm not feeling well. What's wrong? I have abdominal pains. Whatever it may be. Your body is already giving you signs and symptoms to you. Well, we want to make sure you know as future EMTs and future paramedics or nurses or PAs, or if you ever become a doctor, know these signs and symptoms. It's the patient's body telling them something, but it's teaching you at the same time, because you can know all the book and you could be book smart and you could be skill smart too out there, but you have to combine them both when you get out there in the field. And that's how you're going to gain your experience, okay? So make sure you know these words. You always see them on tests. This word always, diffusion. They're going to talk about going from a higher concentration to a lower concentration, okay? I want you to think of oxygen and carbon dioxide crossing the walls of the alveoli, the exchange of those gases and so forth, okay? You need to know that. Higher concentration to lower. When you know that word, just think of diffusion. They use a fancy word, and they give it to you like courses are permeable, membrane, diffuse. You see the word diffuse? The answer is always there. It's the alveoli or alveola. Okay, you could say it in many different terms. Air sacs, alveola, alveoli means the same thing. Okay, make sure you know higher to lower if they ask you that. Here, results in dangerous buildup of waste products, which causes cellular damage. The shock that we're going to teach you, you need to know all different types of shock. And there's a lot in this shock chapter, but I'm going to break it down to you to make it so easy that when they give you a test question in class of the state, you answer like that. Because you know what's distributed shock, what's obstructive shock, the difference between compensated and decompensated, and I'll give you a number. And you'll say, oh, this is much easier now. I understand that. And then I'll give you all the difference of what we call hypovolemic shock, okay, which covers two things, fluid loss or blood loss. And then I'll break down the fluids that your body lose. And you need to know this because it's always test questions. Okay, the pump, the pipes, the contents. You need to know all three of these. The reason why I say it, I want you to use this as a comparison to do with a car engine. the analogy. Car engine would be the pump, the heart. The piping of the car, all those tubes that you see that would be your blood vessels or arteries, the pipes. And then the gas would be your blood. Because when there's a problem in your car engine and it becomes effective, just like your heart, something's wrong, the body's going to show you signs and symptoms. Well, your car, what's going to happen? It's going to come on probably with these fancy computers out and come on the dashboard and show you what's wrong. And then what you got to do is put a little computer there and you know exactly what's wrong with your car because it's all computerized now. But here, you need to know the difference. And we're going to get to this part here. You remember this? Where do you remember seeing something like this? What chapter? Chapter 6. Especially the beginning, the human body. So the test questions they always give you here, do you know the heart? Do you know oxygenated blood and deoxygenated blood? Is there anyone here confused? What side is what comes in where, the flow of blood? Because you need to know this when we get into the heart itself and the different types of shock. Is anyone of you here confused with anything to do with the heart here? So if I give you a question, you will be able to answer it for me. Okay, I'm going to give you a question. Give me the two atrioventricular valves. Atrioventricular.
Bicuspid and tricuspid valves.
Excellent. Excellent. Now, I don't know if that was Kenny or that was someone else because
that was the imposter, Kenny. Jason.
Say that again.
That was the imposter, Kenny. Jason,
change your name.
I know, I'm sorry. I clicked from Zoom, and since then,
Just change your name. Whoever doesn't got their real name, please help me out here. And especially, please make sure you sign in. If you sign in, you're good, because then I won't be able to give you credit and let you know that you all are here. Okay? Someone's speaking. Oh, you guys are too much. Okay, so he is right. Tricuspid and bicuspid, atrioventricular. You need to know that. The questions they would give you after that, when one's open, the other one's closed. So if the tricuspid is open, that means that pulmonary valve is closed because you're thinking of the tricuspid coming down here, and then that pulmonary valve that goes up, it's closed, so the right ventricle could fill up. You need to know this heart. You got to make sure you know all the valves, all the chambers, and so forth. Okay? Another question I give you. All the following are deoxygenated except, and I give you answers. They'll give you superior vena cava, inferior vena cava, pulmonary arteries, pulmonary veins. Out of those four, which one is not deoxygenated?
The pulmonary vein.
The pulmonary vein. It's the only vein that is oxygenated that comes from both lungs to the left atrium. So if you all can remember that for the future and know this heart, you have to make sure you know this heart. Okay? If you're comfortable with it, we'll continue. But now you need to know how some questions could be. Okay? Make sure you know that the right side is always deoxygenated, left side is always oxygenated. Don't forget the septum, okay, and so forth. Easy question. Looking at this heart, I know the word apices. You figure like top, tip, corner, apices, right?
Yes.
Of the heart, which area of the heart is the apices or the apex here?
Top.
Say that again, Maria?
The top of the heart.
No, it's not. It is the bottom. We always think it's the top because we're thinking of the apices like the lungs. And it's the opposite when it comes to the heart. So be careful when they ask questions like that. That's why I want you to know this. And now it's being recorded, so you have this. So you'll know, and you'll see it when you read in your book. Here, they talk about the perfusion triangle. Heart pump function, blood vessel container, blood content functions here. When you look at the damaged heart here, disease, heart pump function, okay, you need to think of things to do with shock. And when you think of pump function, you think of damage of the heart. A lot of these would be associated with what we call cardiogenic shock. If they talk about blood vessels containing function, dilating rapidly, you think a lot of this to do what we call distributed shock. Okay. And if they talk about plasma loss and so forth in fluid, you could also think this of hypovolemic shock. So we're going to just tell you how each one of these perfusion triangle works together. Okay. But how when we get into this to do with shocks, and you're going to see when I bring it up. You need to know systolic and diastolic. If I say 130 over 70, what does the 130 represent?
Systolic.
Systolic doing what? Go ahead, say it.
Constricting.
Contracting, not constricting.
I always get both of those
It's
words.
all right.
fucked
It's
up.
okay. Contracting of the ventricles, especially the left ventricle, right? If I say diastolic, that's a 70. You're going to say not systolic. You're going to say diastolic, what the heart is doing. It's test question.
Resting.
Resting, filling up. You need to know systolic and diastolic, okay? Need to know these words. These are test questions always. You're going to see that they say a pulse pressure less than 25 may be seen in patients with shock. Okay, you got to be careful. There's always a number of like 40 millimeters of mercury or even higher of difference. If the systolic and diastolic was coming close together like this, that's probably a form of what we call obstructive shock called cardiac tamponade. They should be separate and go up and down together. What I mean by that, if I'm 120 over 80, you notice there's 40 millimeters of mercury difference, right? Between the systolic and diastolic. Well, think of something going wrong, gets too close to here, 110, 100, something's wrong. Should not be that close. Should be 40 millimeters of mercury or higher.
Nuki,
Yeah.
so when you're assessing a patient, that could narrow rather quickly, right? While you're monitoring their vitals.
Yes, it can. That means something up. It could be trauma or medical related. What's going on? You need to determine more or less. You're not going to know it automatically, but signs and symptoms don't lie, and especially vital signs. You always take a good set of vital signs so you could give it comparison. But you are right, John, on that. So I want to make sure you know systolic and diastolic, because when we get into obstructive shock, you're going to say, that's what Nuki means. Okay? This very important right here. Pump failure, heart attack, trauma to the heart, obstruct that causes large pulmonary embolism, fluid, trauma, tissues, GI tract, vomiting, diarrhea, fluid components, infection, narcotics, anaphylaxis. You're going to see this play a big role in what comes up right now. This highlighted in your book, but watch this. Automatically, if a person has some kind of cardiogenic shock, they had to have a heart attack. Okay? Had to have a heart attack in order to go to cardiogenic shock. What I mean by that, when a person has a heart attack, and especially on the left side, that left ventricle, okay, within 24 hours, it plays a big role that they are prone to what we call acute pulmonary edema, which is fluid in the lungs. So when the blood pressure is low and things are wrong there, and they're pale, cool, diaphoretic, that patient could go into cardiogenic shock within 24 hours, okay? They may think they have gases. They may not even know they had the damn heart attack, okay? Because they could be elderly, diabetic, a woman, and no offense to you ladies, but women, especially the older, could have those silent MIs, and they are prone to heart attacks sooner than men. Okay? That's statistic wise and research. What you need to know about cardiogenic shock, I need you to know that the muscle, the heart muscle, especially on the left side, is defective. So when you think of cardiogenic shock, think of a heart attack, think of the left ventricle. Why are they prone to pulmonary edema or edema? Because it cannot contract properly, so it backs up where it came from. You got that? That's how you get the fluid in the lungs, what we call pulmonary edema. So cardiogenic shock, I want you to know heart attack, I want you to know a fluid in the lungs within 24 hours possible. The test question they love to give you here, what position will you put this patient on? It says cardiogenic shock, would you lay this patient supine? Kenny saying no. Anyone else?
Yeah, you put them in the Fowler position, right?
Yeah, that's
Yeah.
excellent. That's excellent, Jason. Fowler, semi-Fowler, position of comfort, right? Because just like my drink here, if this is their lungs and they're filling up with fluid, you figure, shock position. I'm taught people, patient in shock, lay them supine. See what you just did to them? You have them drown in their own fluid. You just killed them. Okay, so you do not want to do this. Position of comfort, semi-Fowler, Fowler position. Okay, they may ask you that in the state. So here, be careful. Now this pump failure, all this is to do with pump failure. Here, you see the word obstructive shock? Watch how simple this is. I want you to write the mnemonic CAT, capital C-A-T. Okay, and you're going to say, why the mnemonics? Watch this. If you have C, you got cardiac tamponade. That means, just like in your textbook, it talks about maybe some trauma that maybe occurred, and that there's a sac called precardial sac that surrounds the heart. If that's being filled up where that blood is not supposed to be, it squeezes the heart. It does not let that heart do its proper functions. That's a form of cardiac tamponade or precardial tamponade. Same meaning. You need to know these signs and symptoms called Beck's triad. Always test questions. Beck's triad, just like the beer. B-E-C-K apostrophe S triad. Okay? Look for these three things on a test question, especially, or your patient. JVD, jugular vein distension. Okay? Bulging out. Okay? Muffled heart sounds. And then narrowing pulse pressures. Okay, the blood pressure of systolic and diastolic are coming close together. It's supposed to be this close together, ladies and gentlemen, or is it supposed to be separated?
No, it's supposed to be more separate.
That's right. We're thinking 40 millimeters of mercury or higher. So once you see that, they could give you the test question just by the blood pressures alone. And they'll give you all the numbers, and they want you to figure out what's wrong with these blood pressures. You need to know that if you see a bunch of low blood pressures and you see them getting close together, that is your answer to do with possibly that cardiac tamponade. Okay? If I was to give you a blood pressure like this, watch. I give you 190 over 100, and I give you a pulse rate less than 60, which is bradycardic, like 48. And then I give you erratic breathing pattern, like Cheyne-Stokes. You're thinking, what the hell is this? That's called ICP, intracranial pressure. So I want you to separate and know blood pressures when you see test questions. What is ICP? What is cardiogenic shock? What is to do with cardiac tamponade? What is shock? You're going to notice the blood pressures in shock, how that 90 systolic, and go by that, because I see a lot of test questions with 90. If it's 90 or higher, they could be in a form of what we call compensated shock. So if Nuki's norm was 120 over 80, but you take my blood pressure and it's 98 over 48, am I in a form of compensated shock? Yes. Go by that 90 systolic, because my signs and symptoms still shows that my body's trying to maintain that homeostasis. So I'm compensated. My body's compensated. I'm in compensated shock. When you look at that 90 and it starts going below that, and it goes just below that 90, and I'm still showing the other signs and symptoms like the compensated, or it gets worse, I'm in decompensated shock. So when I highlight that, they'll tell you, you're going to look at it and you're going to say, now I can tell the difference between compensated shock and decompensated shock. And we'll get to that also. But let's go back to this. You got to see. Anyone confused with cardiac tamponade? Okay. Now, remember I said the A? And you say, well, look, there's no A here. I want you to put that A with the word acute. Acute pulmonary embolism. That's why I tell you to spell C-A-T, cat. Right? The reason why I wanted you to spell the C-A-T, now you got C and you got the A, acute pulmonary embolism. That's another easy one of obstructive shock. Obstruction, a blockage, something's going on here. Acute pulmonary embolism mostly starts where? It starts in the lower extremities. Okay, it could be in the arteries or the veins, but mostly comes from the veins after. It travels up the inferior vena cava to the right side of the heart, which is the right atrium, down the tricuspid into the right ventricle. Of course, it's going to contract and go up the pulmonary valve, and right past that pulmonary valve in those pulmonary arteries or at the lungs, that is your embolism. Okay, or what they so-called thromboembolism. Okay. That is your acute pulmonary embolism. You need to know the signs and symptoms, what you see in acute pulmonary embolism or pulmonary embolism. Pleuritic chest pains, pale, cool, diaphoretic, shortness of breath, difficulty breathing, and so forth. Okay, even sometimes possible wheezing. So you got to be careful there. So look for these things on acute pulmonary embolism. You got the A, which is that P there. You got the C, you got the A. Now, tension pneumothorax is the worst of all the pneumothorax. We're going to go over today chest injuries, and you're going to notice that there's a lot of different pneumothorax. Pneumothorax means, just the word pneumothorax means air in the pleural space that causes, majority of times, your lung or that patient's lung to collapse on that affected side. Okay? So there's pneumothorax, hemothorax, hemopneumothorax, spontaneous pneumothorax, okay? Open pneumothorax, aka sunken chest wound, okay? These you all need to know when we get to chest injuries, okay? But when they're not properly taken care of, they can become a tension pneumothorax, which is the worst of them all. This is what you need to know with signs and symptoms. When you read the test question, know they can have JVD, trachea deviation, subcutaneous emphysema. What the hell is that? That's when the patient's breathing in and breathing out. Some of the air comes out and the rest gets trapped underneath the skin in the tissues. And if you ever played with bubble wrap and felt it, that's how it feels on the skin. And if you ever ate Rice Krispies or a form of Rice Krispies and you pour the milk, you heard the snap, crackle, pop when you went like that? That's the sound. So you need to know that word subcutaneous emphysema. Okay? Cyanosis. What's the other ones I'm missing? I did say shortness of breath, difficulty breathing. Cyanosis of the chest, accessory muscle use, possible paradoxal movement, or paradoxal respiration, or paradoxal motion. Those three, one are the same. I've seen it on the state. So if you notice that these three form of obstructive shock is a form of pump failure, but this is the obstructive shock. That's how they give you the test question. You need to know each and every one of these. I tell you to keep the heart separate. Cardiogenic shock, keep it separate. Is there anyone confused on the first four? This is the time to ask, because when you see it on test questions, you better know this, especially in the state. Okay, good. Now watch this. You know what's one of the state test questions? All the following is part of distributed shock except. That's the state. And they'll give you all these or three of these, and then they'll add one of these from the top or bottom or whatever to confuse you. If you don't know what distributed shock means, you're going to get that answer wrong. But now in class and in the state, we need to break down SNAP. Write this down, SNAP. just like that. SNAP, SNAP. And you'll thank me for it at the end. Now, all distributed shocks, just like according to your book, begin with some form of widespread vasodilation. Got that? Widespread vasodilation. So, septic shock, don't think automatic, oh, sepsis, maybe an infection and fever. It's more than that. So when you read a test question, look for the words fever, infection, bacteria, damage or leakage, blood vessels. Got that? Those 5 things in septic. So you think of a person who went to the hospital and they were not feeling well, and then they wind up developing pneumonia. They went to a form of sepsis, okay? Or septic. You know that. Surgery, whatever it may be, okay? They got their gallbladder removed, and then they didn't sew them up correctly, and they wind up developing sepsis. Oh, they're probably going to go into septic shock. Think of those 5 things I just mentioned. That's septic shock. Remember, all 4 of these begin with widespread vasodilation. Now let's think of neurogenic shock. Neurogenic shock, remember you learned in the human body, I think under the nervous system, you learned 3, 4, and 5 keeps you alive. Do you remember that? And you remember everything to do with the brain and spinal column and so forth, right? And all the vertebrates. You need to know that. You need to know that 3, 4, and 5 keeps you alive. If there's some damage in 3, 4, and 5, the patient is going to become paralyzed. Not only that, when there's damage there, especially, the patient loses vascular and muscle tone. Neurogenic shock. It's more to that than just that. They lose their muscular and vascular tone. Normally, when you go down and your body shivers, it's because you're going into what we say hypothermia. So when you lose that muscular and vascular tone in neurogenic shock, you are prone to hypothermia, being hypothermic. The body's not able to shiver. The patient cannot do that because they're losing their vascular and muscle tone. So they are prone to hypothermia. You need to know that. Always a test question. In the male patient, you see this, an erection. This known as priapism. Okay, you need to know that. What happens when they go into neurogenic shock? The blood pools, especially down to the lower extremities in the pelvic area and everything. You need to know that just in case they ask you about neurogenic shock. Okay, that's what cover neurogenic. Remember, again, distributed shock, all of these 4 widespread vasodilation. Anaphylactic shock, you know this one. It's kind of the easiest one, right? Some kind of allergic reaction that got really severe. Look for these signs and symptoms. If you see these 4 things, you got anaphylactic shock. Stridor, upper airway, high-pitched musical, ha or crowing sound. Think of angioedema. Think of the face, the neck area swelling, okay? Angioedema. The stridor sound, inspiration. Look now, lower airway, wheezing upon exhalation, okay? The bronchioles are constricting, inflamed, and possible mucus, okay? So that's 2 so far, upper airway, lower airway. The third one, look at the skin. You will see urticaria, aka hives, okay? That redness, that whole rash that you see there on them, right? And then, last but not least, look at the blood pressure. If the blood pressure starts decreasing and going lower and lower and lower, you know they're going into anaphylactic shock, okay? What's the most important drug we give them besides oxygen?
Epinephrine.
Epinephrine, the epi-auto pen, right? What is the dosage of the adult?
Is it 0.3 or 3?
Yes, 0.3 milligrams. Excellent. You all need to know that. Pediatric,
Well, it would be half of that, so 1.5.
0.15.
Oh,
Yes.
0.15.
Yes, I know. You gotta include that point in the proper place. Yes, because if not, we be getting that test question wrong. Now, the test questions they give you more with that, especially on the state. What does the main job of the epi auto-injector do? What's its main job? And don't tell me tachycardia. What is its main job?
Vasoconstriction.
Vasoconstrictor and what else, Jason? You know it. Vasoconstricting and what it has to do to the lungs.
Dilate.
Dilate them. So you need to you need to know these two words. It's a vasoconstrictor and a bronchial dilator. Those are the test questions they always give class or state. Okay, especially the state. So they ask you about epinephrine, besides making the person tachycardic and all that other stuff they teach you in class and you see in the book, know this for sure. It's a bronchial dilator and a vasoconstrictor. It opens up the bronchioles, open up the lungs, and it constricts the blood vessels. It does the opposite of what occurred. Okay? So that's kind of easy. And you need to know proper place where you give the epinephrine. Remember, it's lateral thigh, mid-lateral thigh, 90-degree angle. Okay? You get them there. You hold it for about 10 seconds. That's the average according to the manufacturer. You discard that, put in shot container, you rub it. Within how many minutes it is possible in a patient that is in true anaphylactic shock who was not treated, they could die. 30 minutes. And the patient goes in true anaphylactic shock and there was no intervention prior to that, that patient could die within 30 minutes of a true anaphylactic reaction. So you need to know that. How long does it take the EpiPen to work? Maybe a minute or two tops. Okay. Can you repeat the dose? Yes. Is it life-threatening and you're going to administer? You can get in contact with medical control. Let's say for some reason, do you still give it? If you are trained in it, you give it. That's according to New York State protocol. So you have to make sure you go back to protocols, read up on anaphylaxis, because they're going to give you test questions from there. So we got last but not least, psychogenic shock. I go to my boy Isaiah and I go, boo! And Isaiah goes, oh! And he passes out. Psychogenic shock. Syncopize, pass out, fainted. That's your psychogenic shock. That's simple, that's easy. Now you have SNAP. So we did how many different types so far? We did obstructive shock that had like 3. We did cardiogenic shock. We did distributed shock. We know it's widespread vasodilation, but we know all 4 of these, SNAP, is a form of widespread vasodilation, and we broke them down. So if they ask you any test question, which one is which, you need to know the signs and symptoms. That's what it comes down to. Now you get this hypovolemic shock. You need to know the word hypovolemic shock. It covers 2 things. You see the word hemorrhagic and non-hemorrhagic. Hypovolemic shock is fluid or blood loss. So if you think of hemorrhagic shock, automatically you're thinking blood loss. We all agree on that? Hemorrhagic shock, blood loss? Now, if I say non-hemorrhagic shock, what is being lost here?
Fluids.
Fluids. Okay. Lewis, can you give me the main 3 fluids that the body loses that will put a patient into hypovolemic shock? Any one of you, if Lewis can't answer it.
Would one be plasma?
Excellent. And why plasma, John?
Oh, geez. I know plasma is a part of the vital function of the blood, right?
Continue.
I think.
It's a substrate for the vessels, for the cells, I mean.
Yes. And when a person gets burned, they lose that fluid, right? So that's 1. So you need to know plasma. Always a test question. Give me the other 2.
Do you mean routes, like the ways in which people lose fluid? Or do you mean the fluid itself?
No, the fluid itself. The fluid itself, the main 3. You got plasma already.
Glucose?
No.
No? Okay.
You don't mean like emesis?
Say that again, Jason.
Emesis, vomit.
Yes, vomiting, emesis. Excellent.
Oh,
So that's
diarrhea.
2. And diarrhea. There you go. Okay. Those are the main 3 I always see on tests. Okay. You need to know all those 3. So when you think of hypovolemic shock, you think of hemorrhagic shock and non-hemorrhagic shock. The main one they always talk about is blood loss, because hypovolemic shock covers both, right? Blood and fluid. And then when it comes to the fluid, need to know about those fluid loss. That's very important. So when a patient's in hypovolemic shock, can hypovolemic shock lead them into a form of severe dehydration?
Yes.
Oh, yeah, for sure. Right? So you need to know, if I lose, and I have done this before, I got some kind of food poisoning when I was younger as an EMT, and I wound up going to hospital because I was vomiting and had diarrhea at the same time. Now, don't ask me how that's possible. Yes, I said the same. I gave the same face Isaiah gave. Like, damn, that's crazy. How could you vomit and diarrhea at the same time? I almost got admitted to the hospital. They started IV. So think of these things when you read these test questions. Know which one is which.
Nuki, I had a question.
Yes.
I know for shock, one of the things that we need to do when we suspect a patient with shock is to oxygenate and also keep them warm. When it comes to keeping a patient warm, I like to go camping, and I learned one thing, that if you start to freeze and you wrap yourself with a Mylar blanket, you could start to sweat, and that could lead to hypothermia. Is that something to look out for with patients who are experiencing shock, to monitor them once you try to keep them warm?
Yes.
Okay.
That's good you brought it up, because it's just like a person who has a burn. What's the first thing people do when they get a burn? Let's say they're cooking or they got burned somehow. What's the first thing they do? They put cold water on it and so forth. Yes, you stop the burning process. But what do people have a tendency of doing that they learned in the past? They take some kind of ointment and they put it on that burn, not knowing that the ointment is making the burn worse. What we used to do, old school, Noxema and toothpaste.
Jeez.
Think about it. This is old school. This is even before my time. Okay. Our parents used to do that. Ask them, how do you take?
I thought it was butter.
Oh, even butter. Thank you, Isaiah. You're right. I forgot the butter. For that, just cook. Put you in the frying pan, cook you. It makes no sense. Yes, you got to be careful there, John or Jason. I forget who just said. I think it was John.
Yeah, it was me.
Thank you, John. I'm trying to look at quickly. It comes up when you talk. It shows like yellow on my side or green. I'm colorblind. But yes, monitor them. They say you got to be careful. What I would do, depending what type of patient I have and where I'm at, I could turn on the heat in the back of my ambulance on low and let it gradually happen. I could put a set up blanket, a light sheet over them, so you have to monitor them. That is part of patient care that you must do. And that's a good question that you brought up. Is there any one of you here confused of the shocks we just went over? Now we're going to get to the good part.
You said that one of the shocks that you don't treat like a regular shock, like keep warm. What was that?
Oh, no, we didn't say we don't keep warm. We said one of the shocks that we don't lay them supine.
Oh, okay. You don't let them supine. Okay.
That was cardiogenic shock. Don't ever do that. Okay, any patient, put it this way. Isaiah and all of you, if you had a patient who had difficulty breathing, cardiogenic shock is one thing. But let's say I'm asthmatic, right? And I'm in a tripod position. Would you lay me supine? Would you lay me all the way back? I'm in a tripod position like this. I can't breathe. Would you lay me all the way back?
No, the body is leaning forward for a reason.
That's right. So you always keep me in that semi-follow position. So you have to be careful when they ask you certain test questions. Think of the position. I'll give you another one. What is the best position to put a patient, and this is a state test question, a best position to put a patient in an overdose or a female patient in her third trimester? What is the best position?
Left lateral recumbent.
That's right. Left lateral recumbent, which you know it as the recovery position. I go old school, and we know it as the coma position. All three of those mean the same thing. But what I see in tests a lot now, recovery or left lateral recumbent. You know what the state says? You put him or her on their side. That's it. That's it. That's a state test question. So that means you must know all these positions you're learning in class and what's the best. For the overdose, supine, left lateral recumbent, because you lay in supine, they're aspirate, they vomit. On a female, third trimester, you lay her supine in a third trimester, the baby and the uterus are putting pressure on the inferior vena cava and will cause supine hypotensive syndrome. In your book, test question always, especially to the state. So know these when it comes to positions. That's why I'm glad we went over, Isaiah, this to do with positions, and that good question you asked before about which one was what that we don't do. That was to do with cardiogenic shock. Now, you remember the 90 systolic I said before? Do you remember the words compensated shock and decompensated shock?
Yes.
Okay, I want you to take compensated shock and think of these signs and symptoms. If my body's compensating, non-compensated shock, I could be restlessness, anxiety, okay? I could be pale, cool, diaphoretic. I could feel like I'm going to die. I could have all those signs and symptoms, right? But I'm above that 90 systolic. My body's trying to maintain that homeostasis. So if my norm was 120 over 80, but you found me and you took a blood pressure and I was 98 or 48, my body's still compensating. So you need to know in your textbook where it says the progression of shock, and it talks about compensated shock, decompensated shock, and irreversible shock, which I'm going to get to in a minute, that your body, when it's compensating, look at the number 90 systolic or higher. If you have two signs and symptoms of inadequate perfusion, okay, which is this PAP pods, because a lot of you are going to say, Nuki, that's a lot in compensated shock to remember. I just sent everyone a mnemonic called PAP pods. So watch this. If I have two signs, or if I see two signs and symptoms of inadequate perfusion, and I have a 90 systolic or better, and I have any of these pop pads, two of those, okay, they're in compensated shock. If I have PAP pods and then 90 below that 90 systolic, they're on decompensated shock. And you're going to say, Nuki, what the hell PAP pods stand for? You need to write this down. So it's tests. Okay. The first P is for pale or pallor. Pale or pallor, which means the same. Okay. Pale or pallor. The A stands for altered mental status. Okay. Altered mental status. AMS. The T is for tachycardia. Okay. Patient has form of tachycardia. The P, the other P, is pale conjunctiva. Remember here? This, my pale conjunctiva, right? The O is orthostatic blood pressure changes. Orthostatic blood pressure changes. Okay? The D is for diaphoresis or diaphoretic, which is profuse sweating. And the S, of course, is on shock. So when you see a test question, try to remember the PAP pods. If you cannot remember the whole listing of the compensated shock, even if you notice in compensated shock, they can have pale or cyanosis around their lips. Is the body still compensating? Yes. When it gets perfused around the whole body, that cyanosis, that's a later sign. That's decompensated shock. The test question they always give, and they put both of those answers in there. I want you to go with low blood pressure. So if they say decompensated shock, and what is the last thing you see that you need to know for sure that they're in decompensated shock? Low blood pressure. Yes, cyanosis is a later sign, but remember, Nuki mentioned that cyanosis can also be in compensated shock around the lips. Is there anyone confused with what I just stated? Look at that cyanotic skin in decompensated shock. Look at the cyanosis around the lips in compensated shock. Now, let's say they're in decompensated shock and they go to this pecking order. Everything is shutting down. Kidneys, you name it. Okay, everything is shutting down. You could give even the patient at the hospital, could give them a blood transfusion and they're still going to die. Irreversible shock. Did I lose anybody? You need to know all those progressions of shock. This is the time to ask. Because when you see these shock questions, you need to know each one.
Can you
John?
just give the, oh, yep, sorry.
Go ahead, John.
Yeah, no, can you just go over like symptoms of irreversible shock? Is that the narrowing blood pressure as well?
Oh, it's everything in the bottom to do with narrowing post pressures, but it's further down. I want you to go to decompensated shock when you have the absence of peripheral pulses and everything's there. Everything is just shutting down. It's a pecking order to do with your organs. So the brain, your heart, your lungs, your kidney, the liver, everything just shutting down. Okay? In other words, John, you're gonna die. There's nothing they could do for you.
All right.
It's rarely you see that on the test question, okay? But you could use that to do with, even if you try to resuscitate them, they're not going to survive. They're dead. They're going to die. What I see test questions always, compensated and decompensated, okay? You'll see irreversible shock in your book, but it's rare that I ever seen it on the state. I hope that helps you. Now, anyone confused with any of these shocks we went over, because the rest of the PowerPoint presentation goes over cardiogenic shock we went over, okay? They have words like preload and afterload. You should highlight that in your book. They may ask you that in LaGuardia as a test question, okay? So if they ask you what's preload and afterload, I always make it simple. Amount of blood to pump, I say pre-contractions. Resistance, afterload. I always go that contraction to resistance against the walls. That's how I teach it, and people tend to understand it a little better. So when you think of afterload, you think of that contractility, that force against the walls itself. So know those words.
Differ from systolic and diastolic blood pressure.
Say that again.
How does that actually different? How is that different than systolic and diastolic blood pressure, though?
When you look at the systolic and diastolic blood pressure, when they ask you the test questions, you have to have good preload and you have to have the afterload there, okay? You need to know for sure the test questions, they always give you that to do with the systolic and diastolic, is that they use the words like increase or decrease to do with, let's say, cardiac output. So if the person is having good cardiac output, can we say they're going to have good preload and afterload? Everything's going to be normal? The answer is yes. So are they going to have good systolic and diastolic? Yes. The test question they give you there, Jason, is when they'll use the opposite words. They'll use words like increase and the other word would be decrease. And you got to remember what I need to have in a sense of preload and afterload. If you have good preload, you're going to have a good systolic and diastolic. So you have an increase of the preload, not a decrease. You follow me? Because the decrease was telling you your cardiac output is not sufficient enough. So that's how it's the easiest way to separate that from systolic and diastolic. The test questions they always give for those two is contractions of the ventricles. If they give you these two words, it's just what does what. Preload, I say pre-contractions. Afterload, the resistance against the walls. But if you need and you see both of them, which you rarely would see on a test question to do with systolic and diastolic, is what I gave you before. Know the systolic and diastolic to do with the ventricles. That's the best way I could make sure you understand it and separate them for you. I hopefully that helped you, Jason.
Yes, it did. Thank you.
You're welcome. Okay, everybody comfortable with obstructive shock? Okay, cardiac tamponade, aka precardial tamponade. Okay, you need to know these. Tension pneumothorax. We're going to go over all the pneumothorax in a little bit. Pulmonary embolism or the acute pulmonary embolism. I gave you CAT. So if you remember all three and you see it on the state of class, just remember CAT. Oh, cardiac tamponade, acute pulmonary embolism, tension pneumothorax, or obstructive shock. You know it. Distributed shock, widespread vasodilation. Okay. Septic shock, neurogenic shock, anaphylactic shock. This excellent table here in your book to do with skin, circulatory, respiratory, and other. Well, if you have this, you look at this. If you look at all these, which ones you know by heart already? Look at the skin. Tell me which one you know already. That, oh, I know that this is easy. Look at them. Can we say we know urticaria? Can we know this, that we got flush or itchy, burning skin that's that redness throughout the whole body? Can we have edema? Yeah. Can we have maybe pale, right? Can we have cyanosis? Possibly. So a lot of these you know. Look at the circulatory. Drop in blood pressure, right? Weak or barely palpable pulses. Okay? Peripheral blood vessels dilated. You know that distributed shock is a form of widespread vasodilation. Look at respiratory. Stridor, upper or lower airway. Stridor, upper, lower. Upper, right? So a lot of this, you know, tightness of the chest, the wheezing, the dyspnea, constriction of the bronchioles, and then, of course, other stuff that could be there. But the main ones here that you see, skin, circulatory, and respiratory for sure. If you notice that on a real patient or on a test question, just look for that. You should be able to answer that with no problem. Psychogenic shock, there you go. Fainting or syncope or syncopizing, right? Passing out. Isaiah passed out on me when I went boo. He got scared, right? Any questions so far? Hypovolemic shock. Okay. Progressions of shock. Any questions on this?
I have one question.
Yes, Isaiah.
About the Becky thing. I keep seeing it, but I can't find it again. You talked about it about stuff that.
Beck's triad?
Yeah, Beck's triad. Yeah.
I want you to go to, and let me find it for you. I want you to go to where it says obstructive shock in your book. Okay, I don't have the page here. Obstructive shock. I'm just looking at my PDF file. You find the obstructive shock yet? Let me know.
I found it.
Okay.
Becky, obstructive shock.
Okay, now, when you go and you see the word, a condition called cardiac tamponade, precardial tamponade in orange, I want you to go all the way down to the bottom. Okay, now you see where it says continued pressure within the pericardial sac, obstructs the blood flow to the heart, resulting in decreased outflow from the heart. Signs and symptoms of cardiac tamponade.
Oh.
That's Beck's triad. These are always test questions. Highlight that. The presence of JVD, distended, means engorged. It's large. It is not going to be collapsed. If you see that word collapse, that is not Beck's triad. That is your answer for not being part of Beck's triad. It will not be collapsed. It will be enlarged. Okay, so highlight that. And then you see the muffled heart sound and the narrowing pulse pressures where you got this systolic and diastolic start merging. That's where they give you the test questions. You got that, Isaiah?
Yes, thank you.
Very welcome. And then goes compensated, decompensated. Okay. I point to it. You tell me what kind of shock. Ready? Major heart attack. Cardiogenic shock.
Cardiogenic.
Severe infection.
Septic.
Sepsis.
Sepsis, septic shock. spinal injury,
Neurogenic.
neurogenic, right? Abdominal or chest injury. That makes you think, right? But think of what happens, abdominal or chest injury. What can you have?
Pulmonary.
Cardiac.
Some shit.
It could be, chest injury could be cardiac tamponade, some kind of obstruction, yes. Or maybe some kind of internal
Be
bleeding.
hemorrhagic.
It could be hemorrhagic, that's right. It could be internal bleeding occurring there, right? Multiple severe fractures.
Hemorrhagic shock.
It could be hemorrhagic shock, right? So you have to look at all these and determine. Now, anaphylactic shock is easy. You need to know more or less also different types of patient with these conditions, what could occur here. It's breaking it down. That's what it comes down to. Now, you know the patient assessment. We went over this. We know more or less what they're going to test you on at the end on the PSC. Me and Lewis spoke about that for everyone to understand. You know your history, secondary. Nothing changes here, vital signs, interventions, and all this. You know all this. Now, care for these shocks. Mostly all cares for shocks, what do we give? What medication is the first one we always give?
Oxygen?
Oxygen. Oxygen is the number one drug we give, right? Is there any other shock that you know of that you could give something else other than oxygen?
Lactic.
Say that again, Lewis.
Anaphylactic shock.
Anaphylactic shock. You could give oxygen plus the epi auto injector, right? All the other shocks, there's not much we could do besides keep them warm, transport, right? Maybe put them in a shock position if they need be, or they are supposed to be in a supine position or shock position. Are they teaching you all shock position in class? Are they still talking about shock position, line supine, elevate the legs 8 to 12 inches above the ground in a 30, 45 degree angle, keep them warm, transport, make sure they have oxygen. Are they saying that to you? Or they say
Yes.
it doesn't make a difference anymore? Someone said, yeah.
Position
Yeah,
of the
they're still
leg.
telling us that.
Yes.
So they're still teaching that, Maria, right? That's what I just heard. Good. So you know what the old shock position used to be called? Modified Trendelenburg. Did they teach you that?
No.
Okay. In your book, unless I missed it, you let me know. This is Trendelenburg. This is the head. Look at my highlighter. You see how it's in a diagonal? This is the head. This is the legs. Trendelenburg. Now watch modified Trendelenburg. The head is here. This is the back, but their legs are elevated. Got it? 8 to 12 inches above the ground, 30 to 45 degree angle, modified Trendelenburg. I don't know if they're still teaching that. That's why I'm asking you all, because some instructors will, some instructors don't. So let me know. I always tell you, educate me if I'm saying something wrong. So you know all this already, the shock position. And immobilizing and talks about the blanket and so forth. And we spoke about cardiogenic shock already. Never give nitroglycerin. Why? Person's had a major heart attack. They found them. Would you give them nitro?
No, because then they'll go tachycardic, right? Wouldn't it speed up their heart rate?
Not tachycardic, bradycardic.
Oh, it would lower their heart rate.
They
Dang.
would lower their heart rate, lower their blood pressure. They may go into cardiac arrest. You bottom them out. It's like me giving a person who just finished having sex, a male patient, and then I forgot to ask him, besides him taking his nitro, did he take his erectile dysfunction medication? They both do the same job. They're going to lower everything. You probably put that person into cardiac arrest. You follow me? So be careful with this. Always a test question. Well, cardiogenic shock, no nitro. Can you give oxygen and aspirin? Yes. Nitro, if they prescribed it, no. Especially if that blood pressure is low.
Nuki, for anaphylactic shock, I had a question regarding the airway. What the airway does swell with anaphylactic shock in some cases, and would that be sort of something they'll get into on the state exam, where what you should do if like there's no way to open the airway for that kind of shock? Would you just call ALS?
You would call ALS. There's nothing you could do in the BLS level. Okay. I have not yet to see a test question besides BVM in the patient, back
Okay.
validation in the patient. That's it. But no, they'll tell you you could try to insert an OPA in there or put in nasopharyngeal airway, in the nose. Otherwise than that, no. Don't worry about that, John. So a
Okay.
question like that will go towards more ALS.
Okay.
You know what I'm trying to say? Like, what would you do in a situation like this? Do you do a criciotomy? Where you cut between the thyroid and the thyroid and the cricoid cartilage? Do you you cut in the cricoid thyroid membrane? That would be an ALS question. No, they would not give that to you.
Okay. Thanks.
Good question. Okay, you did all this. You know this. Treating for it. And obstructive. If we're comfortable on all these shocks and treatment, besides the EpiPen, let's go with some test questions. Give me the answer, put it on the site. Put it on the chat, please. Got to check my sugar, I'm sorry. I'm sweating for some reason. And it could be because it's hot in here. How many degrees is over there, people?
It's 42 right now in Elmhurst.
And it was 72 here.
Oh, I hate it.
I know. And this week is going to be 82, 83, 84.
Yeesh.
Yeah, I'm like, that's hot.
Are you in Florida right now?
No, remember, I live in South Carolina.
Oh, yeah. So, yeah.
Florida's probably worse.
Yeah.
What's the answer, people? Put it on your chat. Okay, Parmesh put B. Someone else tried to put C before, but C is not the answer. Just saying. Okay, you guys and ladies got it. It is B. Shock or hyperperfusion refer to the state of collapse and failure of the cardiovascular system or any one of its components, heart, vascular, blood volume, which leads to inadequate perfusion of body cells and tissues. And then, of course, they get into all these rationales. Remember, I send you, thank you, Kenny, I send you the MP4, I think it's called, Kenny, the PowerPoint presentation and each chapter on your WhatsApp. So you can always look at these at the end of each chapter and look at the rationales. What's number 2? When you look at all this, the best answer here, anaphylactic shock typically associated with what? It's A. It's not bradycardia. Okay, there would probably be tachycardic. Localized welts, no. Okay, severe headache, no. It is A. Urticaria, aka hives, typically associated with allergic reaction, mild, moderate, severe. They are caused by the release of histamines and leukotrienes. That's the words they always use, especially in class, from the immune system. In anaphylactic, urticaria is also accompanied by cool, clammy skin, tachycardia, severe respiratory distress, and hypotension. So remember the way I broke it down for you, because I broke it down. Upper airway, lower airway, what to look for, the skin, and then the blood pressure. And then why each one of these are not. Number 3. Except. accept. When you do accept or not questions, try this trick. Not really a trick, but I've always taught the students this, and I have done it this way too. Signs of compensated shock include all of the following. Read it without the accept. Well, signs of compensated shock include all of the following. Do it include restlessness, anxiety? Yes. Can the patient be pale, cool, diaphoretic? Yes. Can they feel like they're going to die? Yes. Do they have weak or absent peripheral pulses? No. That's decompensated shock. That's your accept answer. Try like that for accept or not questions. I think 99.9% of the time, you get your correct answer. In compensated shock, the body is able to maintain perfusion to the vital organs of the body via the autonomic nervous system. Signs include pale, cool, clammy skin, restlessness or anxiety, feeling of impending doom. They feel like they're going to die. And tachycardia. When the body compensatory mechanism fails, the patient's blood pressure falls. Weak or absent pulses, peripheral pulses indicate this. So there goes correct answer. This is everything you have there for compensated. Number 4. What's the lowest priority? So far, I got a bunch of C's. And C is the answer. It's life over limb, right? So what? They got a bunch of, fractures. Okay. They got hit by a car. They fell off the building, whatever. They got a bunch of fractures. It's life over limb. I need to take care of my ABC, flight threats, and everything else. What's your ultimate splint? The backboard, the longboard. That's the ultimate splint. Put them on there, him or her. They need a trauma center. They need definitive care. They need the hospital. So the answer is C. Critical interventions for trauma patients in shock include spinal precautions, high flow oxygen, or assisted ventilations. Thermal management, rapid transport, and early notification of a trauma center. Splinting fractures should not be performed at the scene if the patient is in critical injury. It takes too long and only delays transport, which makes sense. Okay, number 5. Accept question. Potential causes of cardiogenic shock include all of the following, except, well, if you read it the way I said it before, potential causes of cardiogenic shock include all the following. Could they have inadequate heart function? Oh, yeah. Could they have disease of muscle tissue? Yes. Could they have impaired electrical system? Yes. They would not have a severe bacterial infection. So that is your answer. Remember, we talked about cardiogenic shock. What do you look for? Does anyone remember what impaired electrical system means? That impaired electrical system in your book is probably called cardiac conduction system. That's the one to do with the pacemaker of the heart, of the SA node, the AV node, Purkinje fibers, things like that. Okay, make sure you know those. To do with the electrical system there. That is the SA node, AV node, Purkinje fibers. They will actually test questions on that. Cardiogenic shock is caused by inadequate function of the heart or pump failure. Within certain limits, the heart can adapt to these problems. If too much muscular damage occurs, however, as sometimes happens after a heart attack, the heart no longer functions well. Other causes include disease, injuries, and impaired electrical system. And then why each one? And then why this is the correct answer. Number 6. I'll beat you up, Kenny. Okay, a 60-year-old woman presents with BP 80/60 millimeters of mercury, a pulse rate of 110 beats per minute, model skin, and a temperature of 103.9. She is most likely experienced what? You're thinking of all this, you're thinking probably what? Most likely septic shock. Not this one, not this one, not this one. You're thinking of septic shock of what's occurring, especially look at those blood pressures. That's very low. Okay? In septic shock, bacterial toxins damage the blood vessel walls, causing them to leak and render them unable to constrict. Widespread dilation of the vessels in combination with plasma loss to the injured vessel wall, resulting in shock. A high fever commonly accompany a bacterial infection. That's why Nuki always mentioned fever, infection, bacteria, leakage of damaged blood vessels. Number 7, least likely to present with. Now, this is not a tricky one, but this one's going to make you think, because what I stated earlier, what they lose and so forth. A few of you are putting C. A patient with neurogenic shock would least likely to present with, and the answer is C. C is the answer, and this is the reason. In neurogenic shock, the nerves that control the sympathetic nervous system are compromised. The nervous system responsible for secreting the hormones epinephrine and norepinephrine, which increases the patient's heart rate, constricts the peripheral vascular, and shunts blood to the body's vital organ. Without the release of these hormones, the compensatory effects of tachycardia and peripheral vasoconstrictions are absent. That's why it would not show that. It's interesting, right? Because you know all this, these hormones increase everything. That's your sympathetic nervous system. Your parasympathetic is the opposite of that one. Number 8. I'm getting a bunch of D's. A 20-year-old man was kicked numerous times in the abdomen during an assault. His abdomen is rigid and tender. His heart rate is 120 beats per minute, and his respiration is on 30 beats per minute. You should treat for this patient for. When you really look at this, yes, it's possible to have these, right? Yeah, possibly. But this is where they're trying to get at. It's D, hypovolemic shock. When you look at that, is it possible some form of internal bleeding and things like that? Yes, internal blood loss. The patient may have a liver laceration or ruptured spleen, both of which can cause internal blood loss. However, it is far more important to recognize that the patient is in hypovolemic shock and treat him accordingly. Number 9. A 33-year-old woman presents with generalized rash, facial swelling, and hypotension approximately 10 minutes after being stung by a hornet. Her BP is 70/50 millimeters of mercury and heart rate is 120 beats per minute. In addition to high flow oxygen, this patient is most immediate need of, and you are correct, epinephrine. Okay, for generalized rash, what's the other word we know to look for? Has 2 names.
Hives.
Hives and
Urticaria.
urticaria. Excellent. Give me the facial swelling, another name.
No.
Lewis?
Hmm.
It starts with the letter A, and the other word is with E.
Ecchymosis.
Not ecchymosis,
Facial edema.
which is of the facial, but what we call it angioedema.
Angioedema.
That's what you probably need to look for, okay? So these are just words. They didn't break it down in just plain English for us, but we know the medical terms for these. So when you see like this, you look, okay, rash, they're probably talking about urticaria hives. The facial swelling, oh, angioedema, the face swelling, the neck swelling, and so forth, okay? This patient, anaphylactic shock, a life-threatening overaggravation, of the immune system that results in bronchial constriction and hypotension. After ensuring adequate oxygenation and ventilation, the most important treatment for this patient is epinephrine, which dilates the bronchioles and constricts the vasculature, thus improving breathing and blood pressure, respectively. Number 10, another accept. Impaired tissue perfusion except. That answer that you all put in makes more sense, right? All the following are potential causes of impaired tissue perfusion: pump failure, low fluid volume, or vessel functions. That would be A. An increased number of red blood cells would allow adequate oxygen and nutrients to deliver to the cells. Not bad at all. It's time for a break. How long would you like to take? Because we still got 2 more chapters. 10 so far? 10 sounds good?
Oh no, you didn't see me flip my hands over 3 times.
Oh, was that like 30 minutes? Why 30 minutes? That's too more long. That would be here to like
screwing with you,
9:30, 9:40.
10 minutes good.
Okay, 10. 10 is going to wind up 15. Because Isaiah, like me, we're going to go eat something. Okay, see you on 15. Too funny. All right. We are back. We are going to go over chest injuries. I'm recording it again, okay? Okay, you know this chapter, just like the other ones, National EMS Educational Standard Competencies. I'm going to get into chest injuries to do with trauma. Chest trauma, you need to know open chest wound, impaired objects, what to do, and then blood versus penetrating. Penetrating, I want you to think of a knife, like a stabbing, an ice pick, an arrow, a gunshot wound, whatever it may be, penetrating trauma, okay? Blunt trauma, a lot of blunt trauma, hit by a car, hit with a bat, slap you, whatever, blunt trauma. Other things I need you to know, impaled objects. What do you do with impaled objects? You always stabilize them and then you immobilize them, whatever device you're going to utilize, okay? Hemothorax, penetrating. So we'll talk about, remember the hemothorax, pneumothorax, hemopneumothorax. Going to break those down, okay? This open versus simple versus tension. Tension is the worst for all these pneumothorax. Remember, the word pneumothorax means air in the pleural space, which may cause a collapsed lung. That's what it leads to. Talk about management of them and so forth. Cardiac tamponade, you know what that is. Rib fractures, flail chest, and commotio cordis. Remember that 24-year-old football player, right? he had commotio cordis. We'll talk about that real quick. Make sure you understand that. Air may be collected in the chest, preventing lung expansion. We're going to get into that. And then internal bleeding. A and P need to know the words between ventilations and oxygenation. Always test questions. You learned that before in the human body. You learned that under airway and so forth, and probably respiratory. Okay, don't forget what the word ventilation is. Body ability to move air in and out of the chest, lung tissue. So think of the ambience environment up here in your room to the lungs, okay? And then oxygenation, the process of delivering oxygen to the blood by diffusion, okay? From the alveoli, following inhalation into the lungs. These are words you need to know. And of course, the word, the chest, which is known as a thoracic cage, okay? And the thoracic cavity, what it contains. Remember always to separate the thoracic cavity from the abdominal cavity by the diaphragm. Okay, the diaphragm separates those two. Need to know them. Okay. Let's continue. This is your mediastinum. You need to know all this that's contained between these two lungs. How many lobes on your right lung? 3 lobes. It will be upper, middle, lower. Here would be upper and lower, okay, on your left side. 5 lobes, know that. Mediastinum, all the great blood vessels. Anyone not sure of the great blood vessels? Anyone not sure of everything that we spoke about that's in your mediastinum? The 5 main ones we spoke about, you all good, right? Remember, it's the heart, the great blood vessels, the trachea, the esophagus, and the thymus. That's what I seen on the state. The pleural, they spoke about the pleural covers each lungs. You know that. They may actually, the fluid between those two pleural and visceral, okay, allows the movement on that. There's this word they use called surfactant that helps it rub properly between both the space of the thoracic cavity and your lungs and so forth, called surfactant. That fluid that is necessary for expansion in the alveoli, for contractility, contractions of the alveoli to exchange those gases. The word surfactant. Is that surfactant destroyed? Okay, because of emphysema or chronic bronchitis and things like that, you're going to have lack of that good elasticity. Okay, the word is surfactant. Remember that word just in case they ask you that. Okay, these are all the vital organs. The rib cage is protected. This goes back to what we learned a while back. If they ask you about the sternum, manubrium right here, the body, xiphoid process. They may ask you, what are these 3 parts of the sternum? Manubrium, body, xiphoid process. Please make sure you know that. There goes the mediastinum again. There goes the diaphragm that separates those two that I told you earlier. And then you know these are the active and passive of breathing, inhalation and exhalation. Active, passive. Don't forget the intercostal muscles in the diaphragm contract and so forth. Are there other muscles that you utilize to breathe properly? Yes. Abdominal muscle, pectoral muscles, okay, accessory muscles, intercostal muscles, your diaphragm, okay? This is how they show you it. We've been through this before. This is if someone gets hurt, 5 or below, you see what it says? Spinal column injury below C5 can still breathe from the diaphragm. So if they get 5, 6, and 7 damaged, it is possible that the diaphragm would still work with no problem. They could still become paralyzed, okay? But it's not like 3, 4, and 5 keeps you alive. That diaphragm would still function, okay? So if they give you test questions, know those numbers just in case. Here, you know this one. See where it says, because the pharynx nerve, which causes the diaphragm to contract, originate at 3, 4, and 5. It travels right to 3, 4, and 5, that pharynx nerve, and goes further down. Okay? It's very important to know about the pharynx nerve. Why? Because that's how the brainstem tells and sends a message to the pharynx nerve to tell the diaphragm to breathe normal. Okay? Because the increase of carbon dioxide in the arterial blood. So just remember these just in case they ask you. You know tidal volume, you know minute volume. You know that tidal volume is air that moves in and out in a single breath. In and out, right? The average tidal volume is possibly 500 cc's or 500 mLs. You know the minute volume. How you get minute volume? You calculate that by multiplying the tidal volume by the number of breaths per minute. I really never see that on test questions, but just in case, you know it. Two types, open and closed, we're going to go over. Closed chest injuries, you think of all these. You'll see the word pulmonary contusion or cardiac contusion. All that means a bruising to the heart or bruising to the lungs. Okay? If that heart is damaged, it may not be able to refill the blood, right? And be pumped with enough force out of the heart. Is it possible to result also in cardiogenic shock? That's a possibility. Okay? Remember, can it cause a heart attack? Yes. Lung tissue bruising can result in loss of what we call the surface area when you breathe. So you have a decrease of oxygen and carbon dioxide exchanging. Okay? So can you lead into a person becoming hypoxic or hypoxia? Yes. Or something else? Yes. Rib fractures. Okay? Think of rib fractures. With rib fractures, patient's not going to breathe normal. They can't take full breaths. They have those pursed lips like this. That's how they take their breathing. They don't breathe full breaths like we're breathing right now. Okay? This is penetrating, open. So whatever broke their skin from the outside, a bullet, a knife, ice pick, whatever, the person, if it punctures the lungs, this is going to be considered an open pneumothorax or a sunken chest wound. Okay? We'll get to that a little bit. These are all what blood travel can cause: rib, sternum problems, chest wall fractures, bruising, heart or lungs, right? Cardiac contusion, lung contusion or pulmonary, damage to the aorta, vital organs that attach to the chest cavity can be damaged also to the blunt trauma. You need to know what signs and symptoms you may see when you have chest injuries like that. And you see all this. Is there anyone confused, especially with this word, crepitus? Make sure you know that word crepitus and do not associate that with subcutaneous emphysema. It almost sounds similar, but it's not. Okay? Crepitus, I want you to think of those two bones grinding or grating against each other. Broken bones. It's different from subcutaneous emphysema when it comes to wording in the book. But everything here is a lot of common sense here that you'll know and you probably were taught already. It's more than this, okay? You know penetrating, you know dyspnea, you know bruising to the chest wall, you know pain in the injured site, you know aggregates the pain, localized to increase the breathing. Hematesis, coughing up or spitting up blood, right? You know these. Failure one side or the chest expand normally with inspiration. They associate this with what they call paradoxal motion, paradoxal movement, or paradoxal respiration. In this state, it talks about the opposite side expanding while the other one stays down. It looks like this. So let's say this is my chest wall. This is one side going up and down. So let's say this is my right side, right? And the left side does this, very little. See the difference? That would be a test question in the state opposite side. You know cyanosis, you know diminished lung size, and you know low oxygen saturation of the hemoglobin, something less than 94. Okay, you always want that 94 to 99. How they can breathe, rapid and shallow. You know your patient assessment. It all goes to everything you learned before. Nothing changes here. A, B, C, D, you know, circulation, everything you look for. Here, they have the dozen chest injuries, the deadly, a dozen, table 30-4, 30-1. The one I always see on exams, right here. Airway obstruction, esophageal injury, open pneumothorax, tension pneumothorax, hemothorax, flail chest, cardiac tamponade, thoracic aortic dissection, myocardial contusion, and pulmonary contusion. So the ones I rarely see on exams, you could read up on it in the book, is number 2 and number 3. Well, number 1, 4, 5, 6, 7, 8, 9, 10, 11, 12, I see on exams. Okay, make sure you know that and read that on the deadly dozen chest injuries. Can you read all of them in your book? Of course. But airway, you know, esophageal, you got to read more up on it, and those has to do with your esophagus. Then the open, tension, hemo, flail chest, cardiac tamponade, thoracic aortic dissection, myocardial contusion, and pulmonary contusion could always be test questions on. You know your history, taking the sample, and OPQ, STI, you know your physical exam, DCAT, BTLS, you know your vital signs, you know what you reevaluate all the time. That's that reassessment. And you know the interventions, oxygen, 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 unless you're given something else. Oh, here, very important. Occlusive dressings. Can anyone tell me the main 3 places where you apply an occlusive dressing? The neck is one of them. Excellent. To prevent a pulmonary embolism.
The chest?
The chest and the abdomen.
And the chest and the abdomen. Excellent, excellent, excellent. Okay, so the neck, so no air would go in there, causing, they call it an air embolism or pulmonary embolism. That's the everything covered properly. Okay, all sides taped. That's the neck. You also mentioned the chest. Remember, 4 is for the state, 3 is for the city. Could you use either or? The answer is yes, especially if you work in the city. But no, they're all taped properly, and one corner or one flap is left open for a use as a flutter valve. You need to know that flutter valve. That's to let air escape. The occlusive dressing is placed there so air won't enter. But when air needs to escape because the patient states they can't breathe right, you lift up that flutter valve and the air comes out. Okay, so you need to know that flutter valve just in case.
Nuki, that would be the bottom corner, right? That would be the
Yes.
bottom. Okay.
Now you're talking about the 3 sides or the 4 sides?
3 sides.
Yes, it would be the bottom. I have always left the bottom. So I did it like this. And then that bottom here was my flutter valve. If I did all 4 sides, like I did here, 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 and then I stopped at the corner, and then down here, I stopped in the corner, and they look like this. And you see that the corner here is not attached, it's left separated. That was my little flutter valve.
Oh, interesting.
Okay, so you could do it either way. They are more sophisticated, John, that they got these commercial devices that the agency buy, and it has their own flutter valve. So you could Google that, you'll see it. I forgot what it's called. I think it's called a halo seal. I'm not sure. Someone maybe Google it, Kenny. Yeah, Kenny's already doing it. That man types quick and talks quick. He's fast. But now you guys know, and ladies. And then the last occlusive dressing, I think it was Maria, one of you mentioned the occlusive dressing, the abdominal evisceration. That's the next one we're going to go over. Always a test question. Remember, it's moist sterile dressing first, then the occlusive dressing, and then bulky dressing after that. That's how I always did it. If they're teaching it different, please let me know, okay? Pneumothorax, there it goes. Commonly called a collapsed lung. Air in the pleural space. Okay, we spoke about that. Air entered to a whole chest wall of the surface, air accumulating in the pleural space. Okay, the patient attempts to breathe, causes the lung on one side to collapse. That's your collapsed lung. Okay. Now they talk about blood passing through the collapsed portion of the lung. It's not oxygenated. Breath sounds may be affected. If you have that, you may have a different condition. So be careful. You can have diminished or absent lung sounds. Okay, so be careful there. Now, if you hear nothing, absent breath sounds, I want you to go towards, this got worse. This is probably a tension pneumothorax. Okay? The sunken chest wound or the open pneumothorax, remember, it's that penetration when the hole went through the skin, punctured the lung. Don't forget to push that occlusive dressing there. That's one of the first things you want to do. When you have the sunken sound of inhalation, it sounds like air rushing in, okay, to that chest wall that's been penetrating. So you'll see something like this. Right here. Okay, there goes the wound site, there goes the hole. There goes the collapsed lung. This is your air in the pleural space. When it's blood, or when it's air and blood, that's the hemopneumothorax. So right now, you got a pneumothorax. Can you have a spontaneous pneumothorax? Medical trauma, that is it, Kenny. That's one of them that I remember. And it's called the Ashman chest seal. Thank you. Thank you so much. That's one of them. Interesting, right? There's other devices. What was the halo seal? Was that something else, the halo seal? Did you Google that? Find that one, because I could have sworn there was a video on YouTube to do with the halo seal, and it looks similar to that. Now, let's say you have this pneumothorax here, right? But you had both blood and air. You have the hemopneumo. But I was talking about a spontaneous pneumothorax before I looked at this. A spontaneous pneumothorax is when it's medical or trauma when that lung collapses. Okay? Medical, you think of the word blep, that defect in that lung. Kenny, blep, please. B-L-E-B, and put the meaning in the bottom here in the chat. The blep you need to know, okay? Can the blep cause a spontaneous pneumothorax? The answer is yes, okay? Can trauma cause a spontaneous pneumothorax? Yes. So no spontaneous pneumothorax, please, okay? There you go. Thank you. You see what he put there? I don't know how he does it this quick and copies and pastes whatever, but he is fast. The time I do it, you'll never get the answer. I'm sorry, in the sense of getting it for you. But look at that blep. I think it's spoken about that also in the book, if I remember correctly. So no spontaneous pneumothorax. That open chest wound or that sunken chest wound, that's the one I told you that you need that occlusive dressing. Here it goes. Here goes the one-way valve there, which is the follow valve. Carefully monitor that patient for a tension pneumothorax. Can that tension pneumothorax develop? Yes. You will see a lot of things going wrong here. You will see not only shortness of breath and difficulty breathing, patient could be pale, cool, diaphoretic, cyanosis, JVD, trachea deviation, subcutaneous emphysema. Does it have to have all these? No. Okay. But if you can recognize a lot of these, you know that patient is going into a tension pneumothorax. Okay. So make sure you know that word. So there goes to pneumothorax. There goes from the outside in. That's the open one, open pneumothorax or sunken chest wound. The simple pneumothorax they talk about, this one does not result in major changes in the patient's cardiac physiology. Commonly caused this with blunt trauma like fractured ribs, okay? They will have some signs and symptoms of what we call pleuritic chest pains, dyspnea, shortness of breath, difficulty breathing, tachypnea, breathing fast, use of accessory muscles. The oxygen saturation will be decreased. Okay, know that just in case. They may have crackling sounds in the skin, known as subcutaneous emphysema. This is what we want you to know just in case you see something mentioned about simple pneumothorax. This is what commonly often worsens, deteriorates the tension, develops. Tension is the worst. This is what attention. You need to know this. Ongoing air accumulating in that pleural space, right? Pressure in the chest gradually increases. Complete collapse on one side of that lung. Okay, completely collapse. The mediastinum pushes the opposite of the pleural cavity, and that's how you get that trachea deviation. Okay, the common signs they talk about all the time, and I mentioned some: chest pain, tachycardia, some form of respiratory distress, difficulty breathing, shortness of breath or dyspnea, low oxygen saturation, just like the other one, absent or severe decreased lung sounds on the affected side. Okay? Can they go into a sign of shock? You know that a tension pneumothorax is a form of what type of shock? We went over shock before. Tension pneumothorax falls under CAT. What is CAT? A form of what type of shock?
Obstructive shock.
Obstructed shock. Thank you very much, Maria. Obstructed shock. You need to know that. That's why it mentions that it could go into a form of shock. In that form of shock is to do with the obstructive shock. You need to know that. So make sure. Patient will have JVD, trachea deviation, cyanosis. We already mentioned that. They may need to call the medics to take care of these patients to do what we call a needle decompression. Okay, you've probably seen the movie The Three Kings, right? I think it was Matt Damon and George Clooney and some other actor, I forgot. And remember, some of them happened in the field and they did a needle decompression. That's what we're talking about. And that's how it looks. These are all the other signs and symptoms that you can see leading to that tension pneumothorax, okay? And you see how the pressure is squeezing and how that trachea deviation is occurring here. Instead of being straight, it's moving to one side, okay? So these are the things that you could probably see and what the patient is going through. Know that just in case. You know hemo. There it goes, hemothorax. The blood in the pleural space, the collapsed lung, hemopneumo, air here, blood there. You got them both. Okay? You need to know the difference if they ask you a hemothorax, hemopneumothorax, pneumothorax, spontaneous pneumothorax, tension pneumothorax, open pneumothorax. Signs and symptoms of the hemothorax and the hemopneumo. Okay? You know cardiac tamponade. We already went over this. There goes the normal heart. There goes the sac that surrounds the heart. Cardiac or precardial tamponade. Look how it's squeezing it. Okay? That's where you get your Beck's triad. Okay? Make sure you know that, please. I'll check it again right now. I think it was okay before. I think it was 94. 101, I'm good. Got to make sure because, you know, there goes your Beck's triad, signs and symptoms, ultimental status, pre-hospital treatment, things like that. Rib fractures, you know this. Rib fractures, what you're going to see. You have broken ribs there. The bones are very brittle, okay? You can have fracture in one or up to 4 ribs, depending on the MOI that occurs there. Can those broken ribs possibly puncture a lung? Yes. And it does not have to be an open pneumothorax. It could be a closed injury that the ribs are broken, but one of the ribs from that blunt trauma actually punctured the lung. I seen it. Okay. Seen it on an ex-cop who turned into crack in the early 90s. Okay. And he slipped and fell on the steps going up like the stoop, and it fell. And if you know wooden steps or cement steps, and you're high and you fall and you don't have nothing to stop your fall and you go chest first, you broke the ribs, you break the ribs, those ribs possibly going to puncture the lung, and that's what it did to him. Okay? There goes the signs and symptoms, what we did earlier also, but this is what you have for rib fractures. There goes the shallow respirations and so forth. Oxygen, oxygen, oxygen. These are always test questions. Flail chest, okay, could be caused by two or more adjacent ribs and two or more places that are fractured. Okay, a lot of the times when a person has a flailed chest, you would see that paradoxal motion, paradoxal movement, or paradoxal respirations. Know this word, flailed chest. I always see it on exams. Okay, think of this word right here. Detach a segment of the chest wall, or detach portion moves opposite of normal. This is what you want to know. So think of this flail chest, flail segment, okay? They love to give that on exams. Airway, oxygen, maintain. Nothing new that you don't know what you do already. If they have to be ventilated, you ventilate them and so forth. You know this, we already went over that. That's pulmonary contusion, that's bruising to the lungs. Sternum fractures, clavicle fractures, you learn a lot about fractures. You probably stabilize them depending what's wrong, okay? You can use the arm to protect and just do sling and swab, depending how they wanted to teach you when you're doing fractures, okay? It's not like you do other stuff like you do the humerus and the radius zone and the tib fib and the femur. No. Here you probably use bulky dressing, put the arm over it, or use the arm and do a sling and swab. It all depends. The clavicle you could take care of the sling and swab with no problem. This, they love to give you traumatic asphyxia. You need to know this one. What do you see here? You see distended neck veins. You see cyanosis around their face, the neck, hemorrhage in the sclera, the white portion of their eyes, okay? You see like hemorrhaging there. Some of these patients, you may see little spots around their face, okay? The blood pressure, the blood vessels ruptured called petechiae, okay? Just in case, know that. I had this one before too with a patient.
Gadiro said that patient was deceased in that picture.
Can you look at this patient being deceased? Me, most likely, yeah.
I mean, you have all the signs.
Yeah. When you really look at them, yeah. It looks like they try to do certain things here for him, right? They look like they did a chest tube here.
Yeah, and that's usually from someone getting trapped like under a car or like in some kind of a person versus vehicle, or hit by a car or something like that, right?
Yeah, hit by a car and pin against a pole, tree, a building, and things like that. That is 100% correct. Okay, so you got to know that there's not much you can do for these patients. You can do certain things, and medics could come on scene, but most likely this patient's going to die right there. Okay. And then, of course, they do transport because they don't leave patients like this in the public. You'll see as you learn as an EMT, whoever you work for, you'll be transporting these patients to the morgue. This, blunt trauma to the heart, cardiac contusion. This you must know. Always test questions. What occurs here? You see what it says, a critical portion of the heartbeat? We use the word, the patient is going through that cardiac cycle. That's the word I seen. Right when they're doing their cardiac cycle, the object, bat, baseball, football helmet to the chest, whatever it was, hockey puck, hit them at the right time when they were doing their cardiac cycle and they go into VFib. Okay? No pulse, no breathing. Of course, CPR. Remember that football player, that 24-year-old young man from the Buffalo Bills, I think he was? Okay? Or is? Community recorders. Once I saw that, I said, yep. And then I had students or former students or EMTs and medics now put on my Facebook and say, Nuki, you taught us well. That's community recorders. And they remember that. So these are things you need to know that you may see as test questions or out there in the field as, your real patients. Okay? AD, very important. And then you got lacerating great blood vessels. You could read up on that, Okay. Questions again. This one was pretty quick, and hopefully the abdominal one will be pretty quick also. Give me the answer. Even if you're wrong, don't worry about it. So far, I got 2 B's. And 1 C. That's okay. But the correct answer, when the chest impacts the steering wheel during a motor vehicle crash with rapid deceleration, the result injury that kills almost 1/3 of patient, usually within seconds, is B. Why B? Why the aortic sharing?
Because the aorta pumps the most blood throughout the body.
That's right. And if they shear that and it ruptures or gets injured, they're going to bleed to death. Okay? When the chest impacts the steering wheel following rapid deceleration, forward deceleration, aortic injury, shearing, or rupture are the cause of death in nearly 1/3 of patients. The aorta is the largest artery in the body where it is sheared from its supporting structures or ruptures upright. Estrangulation, bleeding to death, occurs usually within a matter of seconds. That's amazing. No problem. Okay, number 2. Accept questions. Be careful. This is to do with chest injuries. Okay, and getting a few B's here. That's you're putting as your answer. Signs and symptoms of chest injury include all the following except. Well, would you see hemothesis? Possibly. Would you see asymmetric chest movement? Yes. Will you see increase of pain with breathing? Yes. You will not see hematemesis, vomiting up blood. Okay, so the answer should have been B. Let's see if we're correct. Signs and symptoms of chest injury include bruising to the chest walls, instability, increased pain in breathing, asymmetric, unequal chest movement if a pneumothorax is present, and hemothesis, coughing up blood or spitting up blood, if intrapulmonary bleeding is occurring. Hematemesis, vomiting up blood, indicates bleeding in the gastrointestinal tract. That's where you also get that melena. Usually the esophagus or stomach, not the chest cavity. Got that? That's to do with your gastrointestinal tract. Number 3. Remind me to bring more of water to the room, my love.
Yes.
Put it in our little refrigerator. Got my own little refrigerator here in the room,
Office.
Office, kind of, whatever you call this place. This, over here, it's the so-called, what is this actual room called, Margie?
Sunroom?
No, sunroom, morning room, study, office, whatever. I got my command center right here. I got like 3.
You don't play.
I don't play. Yeah, I gotta have all this, my toys. The answer is D. During your assessment, a patient who was stabbed, you can see an open wound to the left anterior chest. Your most immediate action should be to cover the wound with occlusive dressing, right? But if they talk about anything first, what a lot of people normally do, they have their glove hands on and they put a gauze first. That's one of the first things they do, right? Unless you don't see that, you're thinking a chest, you're thinking occlusive. So that is the correct answer.
Because like on a lot of quizzes, it would mention that applying a gloved hand prior, or I think that was like some of the first steps, and that's acceptable, right? Which would be my choice.
It should be depending how that instructor lectured to you and those skills instructor showed you the skill. You have to double check what they taught you. Okay. National Registry will use both of those. Okay. And you're like confused. Follow protocol. What does the protocol say? Does the protocol say first put direct pressure on it with gauze? Then that's what you do. You following me, John?
Yes, I am.
So you got to be careful with that. But you're right, because National Registry will come out and they're talking nationally. Does that automatically have that? Do they have that in the answer, or do they have the occlusive dressing there first, depending where in the chest? So, but that's another good question. So here goes your answer. If you encounter an open chest wound, you must cover it with a occlusive dressing. This will prevent air from moving in and out of the wound. After the dressing is applied, you must monitor the patient for signs of developing a tension pneumothorax, right? Can't breathe right. Oh, lift up that fluid valve. Okay, number 4. So far, I have 2 people, 3 now. When caring for a patient with signs of pneumothorax, your most, immediate concern would be what? C, ventilatory inadequacy. You want to make sure that airway, breathing, circulation, right? A pneumothorax occurs when air enters the pure space and progressively collapses the lung. This impairs the ability of the lung to move air in and out, ventilate. As the lung collapses further, ventilatory efficiency decreases, resulting in hypoxemia. This should be most immediate concern. Some patients with a pneumothorax may also experience an intrathoracic bleeding and associated myocardial injury, depending on the mechanism of injury and the force of the trauma. Number 5. I hope you guys don't mind here, but I have to take off this shirt.
Yeah, sure, no problem.
Always Nuki.
You always do that. Yeah, I guess it is time that Nuki got to take off the shirt because he's like dying here. The fan I should, right? Hold on, I'm going to listen to the wife. I'm going to turn on that fan. Okay, while you guys and ladies answer this. Now I'm looking at the damn monitor and I couldn't see it because I don't have my glasses on. Okay, what purpose does a one-way flutter valve serve when used on a patient with an open pneumothorax? I got some B's and some D's, but the correct answer is B. It allows the release of air trapped in the pleural space. Remember, you open it, lift it up, that's your flutter valve. A one-way flutter valve is used to treat patients with an open pneumothorax, sunken chest wound, and serve 2 purposes. It allows air trapped in the pleural space to escape during exhalation and prevents air from entering the pleural space during inhalation. These combined effects alleviate pressure on the affected lung, which allows it to re-expand. It's so cool how it explains it on the rationale, but you think about it and you visualize it. Number 6. Include all the following except. Remember what we spoke about. What are those signs and symptoms we told you to look out for? I think Isaiah mentioned the word to do with Beck's. Think of Beck's triad, all the 3 things you're supposed to have. Okay, the correct answer? Signs of cardiac tamponade include all the following except C, collapsed jugular veins. They're supposed to be engulfed up, JVD, jugular vein distension. That's Beck's triad, so it have 3 things. So cardiac tamponade, which is almost always caused by penetrating chest trauma, occurs when blood accumulates in the pericardial sac. This impairs the heart's ability to contract and relax. As a result, systolic blood pressure decreases and diastolic blood pressure increases. Remember those narrow impulse pressures we spoke about coming close together? Because the heart cannot adequately eject blood, blood backs up beyond the right atrium, resulting in jugular vein distension, JVD. In some cases, heart tones may be muffled or distant. Other signs include a weak, rapid pulse, and hypotension. That's what you need to know to do with that. So make sure you know Beck's triad. Why all these are correct, and then this one is the correct answer because this is supposed to be, they use the word JVD or they use the word engorged. Okay, engorged. I think it's EN. Okay, number 7. So far, I got 2 B's. The patient experiences severe compression in the chest when trapped between a vehicle and a brick wall. You suspect traumatic asphyxia due to the hemorrhage into the sclera of his eyes. And which other sign? And the correct answer is B. That is correct. B. Cyanosis in the face and neck. The sudden increase in interthoracic pressure results in characteristic appearance, including distended neck veins and hemorrhage into the sclera of the eyes, signaling the busting or bursting of the small blood vessels. You also probably could see petechiae. Number 8. So far, so good to what I'm seeing all of you picking. C, commotio cordis. 14-year-old baseball player was sitting in the chest with a line drive. He is in cardiac arrest, which of the following is the most likely explanation. You know that commotio cordis, that patient went into VFib, right? Ventricular fibrillation. Commotio cordis is blunt chest injury caused by sudden direct blow to the chest that occurs during the critical portion of a patient's heartbeat. Remember that cycle we spoke about? The result may be immediate cardiac arrest. The blunt force causes ventricular fibrillation that responds positively to defibrillation within the first 2 minutes after that injury. Number 9. Yeah, a lot of you picking the correct answer. we spoke about this flared chest. Paradoxal chest movement is typically seen in patients with a flared chest. Remember the words: paradoxal motion, paradoxal respiration, paradoxal movement. That's what you may see in the test. Paradoxal chest movement occurs when the area of the chest wall bulges out during exhalation and collapses during inhalation. This type of abnormal chest movement is seen in patients with a flared chest, a condition which several adjacent ribs are fractured in more than one place, resulting in free-floating segment of fractured ribs. Number 10. Audio man who was the unrestrained driver of a car that hit a tree at a high rate of speed, struck the steering wheel with his chest. He has a large bruise over the sternum and an irregular pulse rate of 120 beats per minute. You should most concerned that he, and the correct answer that I see a lot of you picking so far is A, has injured his myocardium. What would that be called? When you injure your heart, what do we call it?
Cardiac contusion?
Cardiac contusion. Not a pulmonary contusion. That would to do with the lungs. Excellent. A cardiac contusion or bruising of the heart muscle is usually the result of blunt trauma, especially for the center of the chest. In some cases, the injury may be severe that it renders the heart unable to maintain adequate cardiac output. As that result, blood pressure falls. The pulse rate often irregular. However, lethal cardiac dysrhythmia such as pulseless VTAC and ventricular fibrillation are uncommon. Pulseless VTAC and ventricular fibrillation. The reason why I say pulseless VTAC is because they always put VTAC, but it should be pulseless VTAC. That's when the patient has no pulse, no breathing. They're in cardiac arrest. This one should be kind of quick. We won't stay here too long. Okay, so hopefully it'll be a decent day for you all. Similar to what we learned earlier, difference between blunt and penetrating trauma. Okay, evisceration, we went over this, and impaled objects, so it should be pretty quick. You know the difference between solid and hollow organs. Okay, there goes the evisceration again. Then they talk about external genitalia, vaginal bleeding due to trauma, and sexual assault. You know how the abdominal extends from the diaphragm to the pelvis, containing all the organs. They talk about the upper and lower portion of that. You need to know all four quads. Okay, these are your quads coming up. Is there anyone here not sure of the quads or even medical conditions that could occur here? What are the solid and what are the hollow? You need to know it. This is the time. If you're not sure, we clarify everything. If I say solid organs, what mnemonic comes to mind? There's 6 of them we always spoke about, and it starts with the letter O.
OPQRST?
Oh, okay, pals.
Okay.
Oh, okay, sorry, that's for assessment. I'm
It's
sorry.
okay.
Is
That's
for
for
hollow.
assessment. Right, but it's okay, pals, right? So okay, pals is all your solid, right? Ovaries, kidneys, pancreas, right? Adrenal glands, liver, and spleen. That's what we talked about the last time. And the slugs are all your hollow. We said slugs, small and large intestine, everything to do with your urinary, right? Then we put G as your gallbladder and the S as your stomach, right? So you need to know that. So when they give you test questions, you need to know injuries pertaining to this. Okay, and that's your quads, your hollow organs. We already went over this. That's the gallbladder and everything, and how they have the hollow versus the solid. That's how you need to know this. Easy test questions to get. There goes your solid again. You know, they're very vascular, they bleed a lot. Injuries, okay, you got to be careful to abdomen, hollow, solid. These are MOIs, blunt trauma to abdomen, motor vehicle, motorcycle, falls, blasts, pedestrian versus bicycle, rapid deceleration, compression, whatever they talk about that could cause a closed abdominal injury to do with blunt trauma. You know the word abdominal distension, that fluid or blood, organ contents in there. The reason why you have to worry about these closed abdominal injuries, can they cause some form of internal bleeding? Yes, if it hits a solid one, but also if it hits a hollow one. Why? You won't know probably 2 hours later, because in the hollow one, there's always something in there going on. So you need to take good set of vitals and so forth, okay? And that will tell you a lot about your patient. Seat belts, they talk about that in your book, highlight that section. That's to do when it's too high or too low, what it could injure. That's how it looked. This is incorrect position. This is the correct position. Just shows you that in the book. Make sure you know that. Go over that just in case. Foreign objects enter the abdomen, open peritoneal cavity from the outside. Okay, we have a problem. What are we going to do with these patients? Look at that index of suspicion from that mechanism of injury. Low, medium, high velocity, you know, anything that could have done that. Low velocity, you're thinking of knives, other sharp edges, weapons, right? Ice pick, something like that. Here, guns, rifles, okay, bullets, right? Remember these words here? Where is it? Cavitation, always test questions. They love to give you the word trajectory, projectile, cavitation. Make sure you know all three of those words, and they help each other. You need to know the word trajectory, projectile, and cavitation. I always see cavitation on exams.
Cavitation is when that projectile hits the flesh, right? Like the skin,
Yes.
comes into contact.
That's right. This one you're talking about right here. Where is it? This one right here, that pressure waves to the tissue. It does a certain things when it goes in. Okay? That cavitation I always see on exams.
And that's determined by the projectile that's transferring over to the tissue. Like that high projectile would cause the small entrance wound and then a large exit wound, most likely, right? Due to
Yes, but you also have to look at that cavitation to do what velocity would do what. In other words, if you have 45 or 9 millimeter and you got a 22, which one would do the most damage?
the 45.
We always think that, and it's not.
Dang.
22 because of ricocheting inside the body.
That's right. It's the 22 because of that caliber. It could be the same distance away and also that speed and so forth, but it tends to ricochet inside the body. A 9 millimeter or 45 will go through and through, enters and exit. Yes, it's going to do damage, but it's going to go like through and through. The other one would do more damage because that 22 would go inside that skin, hit it, have that form of also of cavitation that you'll see in there, right? But it's going to hit other organs or the bones and ricochet right off of it. So it's the 22. So be careful with that. This one, you always test questions, eviscerations. Is there anyone here not sure how to treat an evisceration? We went over this earlier. All right, beautiful. Hollow organs, spills contents. Remember what I said earlier? Infection, which can take hours or days, because there's always something going on here. So the hollow organ injuries, you probably, and the patient won't realize that until hours later. Okay? Blood trauma, there goes the gallbladder, urinary bladder, contents are damaging, right? Air in the peritoneal cavity, pain, ischemia, infarction. These are to do with hollow organs. Solid organs, you know, they're very vascular. They bleed a lot. What organ in the body is the largest? Especially in the abdominal cavity. Let me make it more specific. Abdominal quads. What organ is the largest organ?
The liver.
The liver, right? If we say of the body, you would say,
Would be the skin.
yeah. So it's test questions. Okay, so read the question carefully. That's how they get you. Okay, there goes the liver. Speaking of the liver, okay, very vascular, can lead to hyperperfusion, shock, right? Do we know and understand the difference between referred pain, radiating pain, colic pain?
What was the third one?
Colic. Do you remember that one? We know radiating pain travels, right? Goes from one spot to the other. It radiates, moves. Referred pain is two pains at the same time. Upper right quad, right? You got a direct pain there, but you also got a referred pain to the right shoulder. What kind of problem you have? Cholecystitis. Okay, to do with fatty foods, spicy foods, and things like that. So they may give you words like that. So know the word radiating pain, referred pain, and colic pain. Does anyone know what colic pain means? You could Google it and put it on the thing here if you want to. I'm waiting for Kenny to put it up.
I googled colic pain, and the first thing is infantile colic. Thing
Yes.
is being done
That's what I
today.
thought of. Yeah.
Say it again.
What? What?
Say what you just
Infantile
said.
colic, known as
Okay.
baby colic.
Yeah. They talk about a lot to do with some form of gases and so forth in there, right? That's what you're talking about, colic, when it's at the infant?
Mm-hmm.
Yeah. So you may see words like that they just throw it in a test question. If you know all three meanings, easier for you to answer that test question. Okay, the spleen and the pancreas went over that. You know they're very vascular, they bleed a lot. The diaphragm, also known as the muscular dome. Make sure you know that just in case they ask you. What are another two organs that are considered retroperitoneal besides the kidneys?
Pancreas and
Pancreas
something
is
else.
one of them.
It's the gallbladder too, isn't it? Because
No. It's the ovaries. Those are tests. They may give you test questions, so be careful. So if you don't see the kidneys there, but you see the word pancreas for retroperitoneal, that's your answer. There goes your kidneys. You know they're very vascular also. Common finding in blood in the urine when they get hit in the kidney area. Flank or retroperitoneal? To the side, flank. You know your patient assessment. You know you're seeing sides up. Primary. A, B, C, D. History taken, OPQ, STI. Right? The sample. There it goes. Decap BTL, that's if it was trauma related. You know your vital signs already. You know your monitoring devices, pulse ox, glucometer to check sugar, blood glucose levels, things like that. You know, do not remove impaled objects. Where's the only two places you can remove an impaled object?
Or CPR, or if it's obstructing the airway.
There you go. CPR, obstructing the airway, like the cheek into the buccal area. Yep. You know your reassessment. Closed abdominal injuries, this is what they say you could do. You notice is oxygen a lot. You know, if patients are unconscious or in shock, you definitely want to give oxygen. I give a conscious patient or unconscious patient always oxygen. To me, it's a drug, and it's a good drug that they need. Do every patient need oxygen? The answer is no. But can you give oxygen? The answer is yes. You know about penetrating injuries. You know about abdominal injuries here. You look at this, how the bandages, if this penetrating is still there, you stabilize it in place. Stabilization, then you immobilize it, whatever devices you use. Donut, and I don't mean donut, you know what I mean? They should have taught you how to take a cavat or the person bandage and how to make it into a little donut to stabilize something. There goes your evisceration. We already went over. That's a test question always. Tell you what you should do and not ever do. You know this already. And then you get into the genitalia. You're going to learn more of this to do with OBGYN and so forth. Okay, if there's some type of bleeding in the vaginal area and you see blood coming out the vagina, you place, or you have the patient place the sanitary napkin or that napkin or that pad there. You want the blood to continue coming out onto that pad. Take those pads with you in one of those bags. I think it's called biohazard bags, and bring it to the ER. Because when the doctor looks at it and they see how soaked it is, it tells them how much they're bleeding, more or less. Okay, so it's good. And that's the male reproductive system, a front view and side view. Okay. Problems that could occur here. What I see a lot with the penis is the zipper getting caught in the males, pediatrics, you know, things like that. You know, is it possible to fracture a penis? The answer is yes. But you're going to say, look, there's no bones there. Yes, because we're thinking automatically bones, but this is to do with tissues of the penis to do with rough sex. Okay, and I mean, then hitting part and not going where it's supposed to be going and hit the bone and actually broke the tissue from the penis. Okay, so they call that actually fractured penis. Okay, there goes a female. You'll learn this a lot to go with OBGYN. Just read up on this. And I'll break down OBGYN for you to do with every part of the female and the male reproductive system, but especially the female, the test questions they love to give you. Make sure you know fallopian tubes, ovaries, fetus, placenta, amniotic sac, you know, first, second, third trimester, know everything to do with the stages of labor. They love to give you test questions on this. Breech presentation, limb, buttocks, cephalic and vertex delivery, which is regular, okay? Crowning, imminent birth. I'm going to break it down to you when we get to that section, when you get to the next few exams. So it makes it easier to answer all those test questions. And there goes your kidneys and the hematoma to the flank region of the side of it, or retroperitoneal. And a urinary bladder. This happens a lot. Alcoholics, people who drink a lot, driving their car, they leave their place, their bar, whatever they were drinking at, the pub, whatever it may be, and a restaurant that they had drinks at, and they drive while they're drunk. They shouldn't be. They get into a car accident and they have trauma that actually ruptures the bladder itself. And this is what could occur. Okay. And you're going to know it's a ruptured bladder once you smell it. Okay. Has that nasty smell. There goes the soft tissue injuries on the genitalia of the male. and then the female. You never impact the vagina. What I mean by that, do not stuff anything in the vagina. Okay? Please make sure. Okay? Remember the pad to the female, sanitary napkin, give it to her, or if not, if she allows you to place it there, you place it there. Otherwise than that, she could do it. Sexual assault and pregnancy, be careful with the bleeding. Sexual assault, you see external bleeding there, look at the word. A sterile absorbent sanitary pad or napkin may be applied to the labia. Okay, do not insert anything into the vagina. Very important. Why does Nuki say nothing into vagina, like any gauze or tampon or anything like that? What can it cause? The ladies should know this.
Air embolism?
Not really an air embolism. It stays there too long.
Shit, I forgot what it's called.
Tampon or the
It's
gauze.
toxic blood
Toxic shock.
toxicity, something like that.
Yes, it's to do with like an infection and a blood toxicity there that is possible. It can happen to the female. That's why a lot of females who do wear tampons, okay, they make sure they don't sleep with that and all this other stuff because it could cause some form of sepsis also. Okay, so make sure you just place that to them or give it to them, okay? Never impact the vagina. You know your patient assessment just like everything else. Seeing size of primary, airway, breathing, circulation. Nothing changes. Any questions so far? Any questions on any of these to take care of? Genitalia for the male, the female. Okay, look at this one. Identify and take of those parts to the bag. Male, if they have the skin in their penis or the scrotum of those, they're telling you, take it with you to the hospital. Amputated penis shaft. Oh my God, you may get that. Oh, Lorena Babbitt, who actually cut off her husband's penis and threw it out the window. Remember that one?
Yeah, Irene was telling us about it.
Okay, so Irene did mention that, right? So she, if she can remember that and go, that she knows exactly. And remember how we taught you to take care an amputated part, right? You know, it's kind of funny. We're laughing on it, but it's just like any other digit or body part, like an amputated leg or foot or hand that you have to cover in moist sterile dressing, put it in a bag, the plastic bag, seal it, and then put it in another bag to keep it cool with ice or cold packs, never directly on ice. Remember that?
Yes.
And the state test question is always state, keep it cool. You'll see it when you do the state test questions. You're going to say, oh, I remember Nuki talking about this, because they always put that one there. I have taken it so many times that I know most of the questions they give you, especially the BLS level besides ALS. And that's it. Everything else here is still the same like we did before. Any questions on this, avulsion, amputation, anything? Do not pack dressing into the vagina again. Okay? Hold dressing in place, diaper type bandage, Rectal bleeding. What's the first thing that comes to you when you got rectal bleeding? Hemorrhoids, internal or external hemorrhage. I had them both before. I know them firsthand, especially internal. Okay? You're going to say, Nuki, how could you have internal hemorrhoids? Okay? We always see the hemorrhoids, it flapping outward, right? And then when you wipe yourself, you see the bright red blood, right? That's what you're looking at. But when it's internal, mine actually lifting up a patient from the ER actually popped. Don't ask me how, just popped. You would know something was wrong when you see me walking with the stretcher and I'm squeezing my butt cheeks. Yes, I know. It's funny.
That's painful. No, I'm sorry. That's
Yeah.
horrible.
And you know what's worse about that? And I bring this up to you so you can learn this. I just had a colonoscopy done. Okay. So you know how embarrassing it is when I'm in the ER in my right lateral recumbent in front of two female doctors who had to check me. And I just came out the bathroom and I tell them this, and it's funny. I said, docs, I know you're going to check me now, but remember I had tissue, paper toilet covering that there because I was bleeding. Don't worry about it, Mr. Nuka, we got you. And all you hear is the gloves and lube, and then they use the forceps. And they open up Nuki's anus like Pac-Man is eating something, like the alien, like they're going to check my prostate. And it's true. I want you to know these things. So if you ever hear patient explaining this to you, it doesn't freak you out. You say, that's interesting, because that's what they do. So just wanted to bring that out. So can
Nuki,
you have rectal bleeding to do with hemorrhoids? What other rectal bleeding can give you? What other bleeding that you could see that there will be blood in it? What is it called?
Is it like a GI bleed?
It is a GI bleed. And that's to do, part of it is to do with melanoma. Remember that tarry one, that tarry black in color? There's another one that you can see, it's where the blood is there because it's a form of digestion. And it's to do with blood there that came out to do with your digestive system. Do you guys remember it or have heard of it? Starts with the letter H. When you get a chance, Google that, digestive blood, okay? Coming out in the stew. Now, there's two different words they'll use. They'll use the melana and another one. And see if Kenny could get it, because I know he loves to Google stuff. Sexual
You said it
assault.
starts with what?
I think the letter H, if I remember correctly.
I'm gonna butcher the the pronunciation. Hemotichesia.
Yep, that's it. When you get a chance, put the meaning on here for everybody.
Yeah, I got you.
Okay? Sexual assault. You get this test question here, you look at the sexual assault, rape, assault, whatever's there. Do not mess with the evidence. Do not let them shower, take a bath, whatever. Clean themselves, anything. Okay, they need to go to the doctors, to the ER like that. When you take their clothing, test question stayed in class always says paper or plastic that you put it in. Which one you think you put it in, paper or plastic?
plastic?
No, it's actually paper. Paper lets it, the evidence and let's say whatever is there, semen, blood, DNA, whatever is there, stay its norm. But when you put them in plastic, it tends to separate and then starts getting mold. Okay, so remember, paper or plastic, go with paper. It's directly from your book under the rape and sexual assaults, okay? That's a test question I always see. Trying to see if I see it here for you. Advise patient not to wash, bath, shower, douche, urinate, defecate until exam. And that's it. Okay, questions. Let's go. Questions. We're almost done. It's going to be a quicker day or evening. Okay, so far, a lot of you put in D. Peritonitis will most likely result following injury to the stomach. Peritonitis, inflammation of, you know this. Okay, in general, solid organs bleed with an injury and hollow organs spill their contents into abdominal cavity, resulting in peritonitis, inflammation in the intra-abdominal lining. Of the choices listed, the stomach is the only hollow organ. Number 2. Yep, a lot of you are putting the correct answer so far because you're thinking of bleeding profusely. You got to think of things that are very solid, right? The liver is very vascular. Makes sense. Kidneys are also, but what makes it liver supersede the kidneys? Not only the larger size of that organ, but more of the blood volume. The liver is highly vascular solid organ and contains approximately 40% of the body's total volume at any given time. In severely injured, bleeding from the liver would be profuse and rapid. Other solid organs, such as the spleen and kidneys, may also produce severe bleeding if injured, though not as rapid as the liver. The stomach and gallbladder are hollow organs. If lacerated, they would spill their contents into the abdominal cavity, resulting in peritonitis. Number 3. So far, getting a few of you putting C. Which of the following statements regarding intra-abdominal bleeding is false? The correct answer is C. The absence of pain and tenderness rules out intra-abdominal bleeding. That is incorrect. Would you have this, and that? Yes. Intra-abdominal bleeding is commonly found following blunt trauma to the abdomen. Signs include abdominal distension, rigidity, bruising may not occur immediately, and in some cases, pain to palpation. However, unlike gastric juices and bacteria, blood within the abdominal cavity does not provoke an inflammatory response. Therefore, the absence of pain and tenderness does not rule out internal bleeding. Number 4. To do with your seatbelts. Read it carefully. God bless you, my love.
Thank you.
Even when seatbelts are worn properly and the airbags deploy, injuries may occur to the what? Well, remember we're thinking about the seatbelts. Remember what we spoke about proper placement of those seatbelts. Okay? Especially which portion? A lot of you did put the correct answer is the iliac crest. Seatbelts should be positioned over the iliac crest of the pelvis. If they are positioned higher, significant intra-abdominal injury can occur, even when seatbelts are properly positioned and the air blocks deploy. Injury to the iliac crest may occur as the locking mechanism of the seatbelt engages during a motor vehicle crash that involves rapid deceleration. This is to do too high. Seatbelts are worn properly, extremities. There goes the correct answer, and lower rib cage. Seatbelts are worn too high. Number 5. Think of steering wheel, right? Abdominal injury. When you think of the steering wheel, right? You look at it, we have told you and spoke about first, second, and third collision. We've spoken about you knowing the mechanism of injury and then the index of suspicion. And we talked to you and spoke about lifting up the airbag if it was deployed and looking at that steering wheel. Because if you look at that steering wheel, depending how they're seated, it can not only be chest injuries, could it be also abdominal injuries. Okay?
Yeah, I remember for this question, at first I was like, oh, it's the instrument panel. But then I realized driver, the steering wheel's there. And if it was a passenger, it would be the instrument, the dashboard, right?
Yes, it could be the dashboard if it was the passenger, but if it's the steering wheel,
Is a driver.
the driver, you have to go with that deformed steering wheel. Airbags save lives when used in conjunction with proper worn seat belts. Unfortunately, however, not all drivers wear their seat belts. If unrestrained, the driver abdomen may strike the steering wheel, resulting in significant trauma. Suspect this if you lift the airbag and note that the lower part of the steering wheel is deformed. So you have to look for that. Okay, number 6. You know this one. You know the word evisceration. You know what you were taught. What do you put on an evisceration? Makes sense, right? A lot of you are putting D, applying occlusive dressing cured by trauma dressing, right? So they put the occlusive dressing and trauma dressing over that, but what would you put before the occlusive dressing on top of them? What type of gauze? What type of dressing? That's a word I'm looking for.
Sterile dressing?
Besides sterile, it should be what? Starts with the letter M.
Moist.
Moist.
Moist sterile dressing.
Moist sterile dressing. Very important. So if the evisceration was there, of course, you're going to try to move it back in place the best way you can, right? Then you're going to put moist sterile dressing on top of that, right? Then the occlusive on top of that, right? And then you probably cover it with a dry dressing. That's what a lot, and we were taught in the past. So that's what they said secured by trauma dressing, which is like a size 10 by 30. Although the preferred management of abdominal evisceration includes the application of a moist sterile dressing covered by a dry dressing, protocols in some EMS systems call for an occlusive dressing. So you should have been taught moist sterile dressing, occlusive, and then the dry. Have you guys ever heard of the PASG or the mass bands?
I'm ready for you. Pneumatic anti-shock garment.
Pneumatic anti-shock garment. Excellent. And then the MAST, M-A-S-T, military anti-shock trousers. They're one of the same. Okay? Know that word just in case. It could be old school test question they give you here. If you ever see this, think of a unstable pelvic fracture that you need to utilize this mass pants or PASG, or a systolic blood pressure of 50 or below. That's old school. There you go. That's the old mass pants. So if you think of 90 and below with an unstable pelvic fracture, mass or PASG, in case they ever ask you that test question. If it's 50 or below systolic, mass pants, just in case. If you ever see that, take National Registry. What's number 7? A lot of us think it's to sit up, but it's incorrect. Transporting a patient with possible peritonitis following trauma to the abdomen, which position would be most likely preferred to assume? And when you really think of it, you think on his or her side, right? And then you think maybe legs outstretched. It would be actually B, legs drawn up, possibly on their left or right side, but drawn up like the fetal position to prevent the legs from being extended outward because it causes more pain for them. So like the fetal position, like balling up like in a little ball, that's how they do it. So Patients with peritonitis often lie very still and tend to have their legs drawn up into their abdomen. This relieves strain on the abdominal muscles and may provide pain relief. Almost like they use the word, I think it's form of guarding. I think it's the word guarding in the textbook.
Yeah, so guarding would be, I mean, it would be voluntary and involuntary guarding, right, Nuki? Like,
Yeah,
depending on, well, like the injury, like for an abdominal injury, would that be more of a involuntary guarding?
when you mean involuntary guarding, what you mean, that they automatically do it, or is just
Yeah, like it would be automatic. Well, I know voluntary guarding is like because of the pain, they don't want any. This I'm trying to just remember from the textbook. I think involuntary was like the muscles actually instinctively like guard that area from being injured further. And I was wondering if that would be for more like an abdominal.
I see where you're going with it now, and the answer is yes.
Okay.
Because if I know if I have any stomach pains, even if you don't go into a form of trauma, you ever notice when you do have any stomach, like gases or something bothering your stomach, you have a tendency of bringing up your legs towards your chest area or your stomach to relieve the pain, and then maybe sleeping on your side and putting something between your legs or even underneath the stomach?
Yes.
It's the same thing. Even when you feel nauseated or have certain gases, you never notice that you're always on your side with your legs, knees drawn up towards the chest area? It's the same thing. Good. I love the way you went over that, John.
Thanks.
Okay, we went. Hold on. Did we went over this one? No, we did it, right? 16-year-old boy was playing football and was struck in the left flank during a tackle. His vital signs are stable. However, he has severe pain. You should be most concerned that he has injury. Now you guys and ladies are putting the answers. I'm sorry about that. A lot of you putting C, and C is the correct answer. Okay? The flanks are located laterally to the back and overlay the kidneys. During football, sparing injuries occur when a player is struck in the flank by another player's helmet. This can result in kidneys ranging from bruising to severe bleeding. Injury to the liver, spleen, and bladder will more likely occur following blood trauma to the anterior abdomen, or they call the true anterior abdomen. You'll see test questions like that. Number 9. This you can see a lot in patients like in that football playing or have a history of kidney stones and things like that. Blood in the urine. Just broke down the words, right? That was the easy one. Blood in the urine called hematuria. Following trauma, the presence of hematuria suggests injury to the urinary bladder or kidneys. Bright red blood in the stool is called hemochasia. Dark tarry stool are called melanoma. Vomiting of blood is called hematasia. There goes red blood in the stool is called, I think that's the word you put up before, Kenny? Hemochasia, if I remember correctly.
Yes. Sorry, I was nodding.
That's all right. Number 10. We're almost done. What should you do here? When caring for a female with trauma to extend external genitalia, the EMT should do what? Are you going to carefully pack the vagina to reduce bleeding? No? Remove any impaled objects from the vagina? Cover any open wounds with moist sterile dressing? Mostly when you're doing this, what kind of dressing you're doing there? It's going to be dry, right? Sterile? It is a. Bleeding from the external genitalia should be controlled by applying a dry sterile dressing and local direct pressure. Never pack anything to the vagina to try to control bleeding. The increase of the risk of infection and anything you place into the vagina will only need to be removed at the hospital. Impaled objects in the genitalia should be carefully stabilized and plate, not removed. Not bad. Not bad at all. All right, let me double check and make sure. Okay, make sure we went over this. We went over the chest and all the parts to do with the chest, from the mediastinum to all the pneumothoraxes, hemopneumo, tension, spontaneous, open, pneumothorax. We went over words like flutter valve, occlusive dressing. We spoke about flail segments. We spoke about broken ribs. We spoke about paradoxal motion, movement, and respirations. We spoke about VFib, VTAC, the defibrillator that should be utilized. We spoke about cardiac tamponade, commotio cordis, cardiac contusion, pulmonary contusion, traumatic asphyxia. We went over words like cardiac output, stroke volume, tidal volume. We spoke about all the quads and all the solid organs and hollow organs. We spoke about referred pain, radiating pain, colic pain. We spoke about melena, hemachasia, hematuria. We spoke about all the shocks: compensated shock, decompensated shock, cardiogenic shock, obstructive shock, distributed shock, irreversible shock. I mentioned incident shock, right? To do with the sugar being very low, right? I think I said the word hypoglycemia, not hyper. Anything hyper, I think Kenny mentioned going into DKA, and it could get worse. You could go into HHNS, hyperosmotic, hyperglycemic, non-ketonic syndrome, or coma. Okay? Going sugar very, 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 very high, hyperglycemia, going all the way up in those numbers, diabetic coma. Okay, so when you get into diabetes, make sure you know that. Yeah, right? We spoke about impaled objects, where to remove them, how to stabilize them, and so forth. We spoke about recently a bunch of abdominal injuries. Okay, what to look for. Make sure you look for those signs and symptoms. Okay, from rigidity to pain to nausea, vomiting, to hemoptysis or hematasia or hematemesis and so forth. We spoke about all the shocks. Okay, is anyone confused with any of the shocks? Hypovolemic shock, hemorrhagic shock, what could cause them? Just want to make sure. So everybody comfortable with cardiogenic shock, distributed shock, obstructed shock, hypovolemic shock? Okay, beautiful. Distributed shock, septic, neurogenic, anaphylactic, and psychogenic. When you lose plasma, what type of shock is this? Loss.
Hypovolemic.
Hypovolemic. Hypovolemic covers fluid and blood loss. Excellent. Is plasma part of hypovolemic shock? Yes, it's the fluid. The three main fluids we spoke about, which was plasma was one of them, diarrhea, and a lot of vomiting. We spoke about chest injuries. You need to know everything to do with chest injuries. You need to know the signs and symptoms. Is there anyone here not comfortable with the word chest injury? You need to know those signs and symptoms. Do you remember them? What do you see? Can anyone tell me, what do you see? Get a chest injury. What's one of the first things you're going to see? They get hit in the chest.
Bruising,
Bruising, right? Form of ecchymosis. What else?
crepitus,
Maybe crepitus. That's possible. What else? They get hit in the chest.
Unequal chest rise.
Unequal chest rise, right? Possible if there's fractured ribs or a flailed segment, right? So things like that. Can they cough or spit up blood? Yes. Hemoptysis. So you need to know the signs and symptoms of chest injuries. Besides other problems that occur here, like a pneumothorax, hemopneumothorax, spontaneous, everything. You need to know this. Commotio cordis, okay? We spoke about cardiac tamponade. We spoke about the abdomen with peritonitis. We spoke about all the quads, everything that's located in each quad. Is there anyone confused with organs located in any of the quads? Okay. Anybody confused with the chest wall when I say the word mediastinum? Okay. Make sure you know the word mediastinum. Septic shock, neurogenic shock, anaphylactic, and psychogenic. Make sure you know all those shocks and the signs and symptoms for each and what to look for, especially in neurogenic shock. What is not there and why. We spoke about the genitalia area, what they want you to do, how you take care. Female and male genitalia, from the penis to the vaginal opening, the vagina. We spoke about impaled objects. We spoke about entrance wounds and exit wounds, like through and through. Cavitation. Occlusive dressing. Subcutaneous emphysema. Flutter valve. Compensated and decompensated shock. Cardiac contusion, pulmonary contusion, JVD, muffled heart sounds, narrow impulse pressures, engorged JVD, not that other word they use. I think they use the word collapse. We spoke how you treat a patient in shock and what you're supposed to do for them. That's it. It covers everything. Everything I see, we went over. So everything I just mentioned to you all, make sure you go back to this video, okay? Make sure you understand all that material, and you should do very well in your next exam. Otherwise than that, I'm going to stop the recording here.